everyone to the meeting, the Oxleas Board of Directors. Usual appeals, please. Keep microphones on mute when you're not speaking. Raise hands when you want to speak. If I don't see it, others let me know, and then Sally normally gives me a text message or whatever to remind me if someone's got a hand raised. Thanks very much for our governors who are listening in. We've had a series of questions from the governors which should be answered through the meeting today. If they're not, we can have a wrap up at the end to make sure that we have covered them all. And whilst this is a meeting in public rather than a public meeting, I'm very happy for governors to raise anything throughout the meeting should they wish to do so. So we'll make a start. Do we have any apologies? I did have an apology from Amran, and I don't know if Steve has joined us this morning, but I know that there may be a reason why he might not be here. Sally, have you had any other apologies for absence? Any declarations of interest, conflict of interest? No. We go on to the minutes of the last meeting and go through those accuracy and go page 1. Crikey, there's 10. 2, 3, sing out please, I can't see the screen while we're doing this. 4, 5, 6, 7, 8, 9, and 10. On the matters arising, Sally, health and safety?
Yes, so we brought the committee's paper to the board in November, which agreed the current responsibilities around health and safety. But this is an area that we are looking at further, and we will have a discussion. We're planning for our February Way Day, assuming that we are able to continue and have that meeting. So I think this is something that we will return to. But probably in a kind of greater in the round rather than specifically on the reporting route. I think we need to have a look at the whole picture and then adapt our reporting route accordingly.
Thanks. On the board assurance framework, we've got staffing levels. And we've got ligatures, and there's 136 on that first page. I think all of those matters, Matthew, are going to crop up during the body of the reports, are they not?
I think they will do, Andy, yeah.
So unless anyone objects, those will crop up, as will, I think, all the other matters on the risk register. I've been through that, and I think everything should be covered through the report today. But if we don't, I'm very happy for anyone to raise that at any stage throughout. And I know Sally's keeping an eye on that to make sure that everything is going to be covered on that. That being the case, then we'll go on to the next item. Asking on that one, which is
me.
Yeah, I'm just going back up to where I was. Yeah, so next item, which is your report, please, Matthew. Thank you.
Okay, thanks. Good morning, everyone. So, I mean, COVID, I won't say much more than's in the report, really, but we're delighted to say that we've got our staff vaccination programme starting this week. We were informed on Tuesday by NHS England that we'd expect our first delivery. The delivery arrived yesterday, and we vaccinated 50 staff yesterday afternoon just to test the systems. There'll be 250 more a day through now until Sunday, and that'll be the first set of 900 vaccines used. And it's the AstraZeneca, the Oxford vaccine that we've received. The schedule that we've received from the South East London system says we should be at 900 a week now for the next couple of weeks, with the intention that we've got the vast majority of our staff vaccinated running into February. And I have to say, it was lovely this morning. I suppose I was caught slightly by surprise by quite how emotional it was, both for the staff who were given the vaccines, who are all really excited and really keyed up to get going, and also the people waiting for them as well. And I was talking to a couple of our staff who were there, some of whom were in this sort of clinically vulnerable group, and others who were working in service delivery jobs, and they were just talking about how it felt sort of seeing that there's something happening now that offers protection and offers a way through this, and it was lovely to see actually. And as we get those more numbers through, we'll keep information on the Ox about how you can register yourself for them. Just to say, the supply element is out of our hands. That's dependent on NHS England, but we have everything up geared to go. So as soon as we get the stocks, we'll keep them rolling through. And my expectation is that by the end of Sunday, with the staff that have already accessed available vaccines through some of our primary care networks as well, we should see around 1,000 of our staff vaccinated by the end of the week, which is really fantastic news actually. And I think we can see at the minute that the new variant B117, there's now a good evidence base to suggest it's much more transmissible. So I think the vaccines come along at a good time, but it does mean that the whole system's been under really quite incredible pressure, and markedly worse than it was in March, April last year, which I think had we known that then would have been rather daunting. The system is working tremendously hard, and I'm sure Ian will say more in his operational update about what we're doing to keep things going. But there are some promising signs that this lockdown, which is weaker, I think, than the one we had last March, based on mobility data, but it is starting to have an effect. I think, though, because of the rather less restrictive nature of the lockdown, and because of the more contagious nature of this variant, is likely to take a longer period before we get back to the levels we were in. Where we can feel really confident about saying that we're on top of COVID. If you remember, in the summer, we had rates of below 20 people per 100,000, and Public Health England were worrying about it creeping into the 20s. And we're now in a situation where there's barely a London borough that isn't over 1,000 people per 100,000, you know, and we've been in this situation where 1 in 30 London residents has apparently got it. So it's been a very difficult time, but I think we all have probably read and heard enough about COVID, and there's not a great deal more I can add other than to say keep your eye on the Ox and get yourself vaccinated. We want to prioritise clinical and patient-facing staff first. So when you do see it come up, you know, think about when you put yourself forward for it, but we'll be very clear when we want people to take part. There's some more information in there on building a fairer Oxleas. There's an exchange of letters we had with CQC that we've published that shows the letters to us following a meeting with some of our staff and our response. And if you haven't read that, I very much encourage that. And we'll be talking today about our new values and behaviours framework. And we've also got our first shadow executive session under our belts. We met the shadow exec on Monday. They had full access to our exec papers. And a number of us spent some time with them, and that was then fed into the discussions at the executive team yesterday. And I have to say it was fantastic, getting a very different perspective on how the trust is run from them. I suggest we probably bring something substantial to the board in a couple of months' time about how that's working for us. And I think it'd also be useful for the board to meet the shadow exec and talk to them once they've been through a couple of cycles with this as well. But I have to say they did offer some perspectives on the things we were talking about that were extremely helpful, but also ones that I think it would have been difficult for us to pull out through the usual exec approach as well. And I think it's really important for us as a trust that we continue to create this space to hear from staff with a range of different experiences and backgrounds who are working across the trust. So we'll hear more from them over the course of 2021. We've other things in my update were just about a couple of our conferences, and thanks to the comms team who've been helping us keep things like the annual members meeting and the nursing conference going virtually. I think we've all become very familiar with Teams now, but actually the great thing is that we're managing to use it to do our business, but also to do engagement and discussion and to offer therapy, you know, which is really coming to its own. And that's thanks in part to the comms team and also to our fantastic ICT team who provided us with the infrastructure to do this. And then there's a bit in my paper about the integrating care proposals that are working their way through NHS England, some proposals there to create stronger partnerships on a statutory basis for integrated care systems. And in South East London, that is us, Lewisham and Greenwich, Slam, Kings, Guy's and St Thomas's, and our range of community and primary care partners and local authority partners across South East London. We'll hear more about that over the course of this year. And also significantly yesterday was the publication of Mental Health White Paper. And we'll bring a more detailed update to the board in due course on this. But it's worth just talking about the key elements of that we'll need to consider. First, there's a big emphasis on there on giving patients more control over the care they receive, including a greater role for advocacy, more routes to challenge decisions that are taken about people's care, about the introduction of nominated individuals and a stronger set of statutory care and treatment plans in the patient's care plan to give people more rights. There's a sense that the Act, which has been in place for 40 years now, is too heavily on the restrictive side. So there's a move here to try to open it up and make it much more about the patient's care than just about decisions taken about them. And also something in there we'll have to look at about the provision of ensuite for everyone as well. So we do need to look at our estate and start to get ourselves ready for addressing that. Another big thing in there is about the disparities between the use of the Act to detain people from BAME backgrounds. We see this quite strongly in the London data, particularly around the experience of black men who are much more likely to be detained and who are also less likely to access community and primary care support around mental health. So although we look at the detained element of this, actually it's got implications for the whole way in which we deliver mental health care in the community, including through general practice. And the patient and carer race equality framework is going to be a big part of that. And our neighbours in SLAM are one of the pilot sites nationally for that framework as well. So we'll be able to learn from them through our relationship with the South London Partnership. The sort of third plank is greater access to forensic care for people in the criminal justice system who need access to mental health support, including more rapid access to support through custody suites. And these are services that Oxleas, in its role as lead provider for forensic care, has a big part to play. And so we'll have to keep a very close eye on the implications both for supply and demand of forensic support, but also for the responsiveness of forensic services to people who are within the mental health and criminal justice system who do need access there. I'm confident with our strong track record in this area that we'll be well placed to respond to that. And the fourth sort of pillar, as the Secretary of State described it, is around learning disabilities and autism, where they have put in now a restriction, or they will do through legislation, on how long people can be detained when learning disabilities or autism are the reason for the detention, with no other elements to their illness as well. So that's going to be a really quite important change in the way in which, particularly long-term locked care is delivered to people with LD and autism. So that's very welcome too. So we'll be working through the policy implications of this and discussing with SLAM and other partners how we're best to respond to it. And we have a board session in February, and I think it'd be worth us spending a bit of time looking at that then. So they were the key things I wanted to bring up today. I could probably talk for an hour about COVID if we wanted to, but to be honest, I think we spent enough time on it. So, and Ian will talk about the operational impact there, but just to say that our staff are doing a tremendous job. You know, we've seen our absence rate ticking up slowly to the point where I think we've now got around 160 staff off due to COVID and other reasons, you know, which puts us about just over 6% organisationally. That, compared to some of our neighbours, is still a pretty good place to be in. And I think it's a sign that, you know, people across the Trust are working very, very hard to keep our services going, including to make sure that people who are under community services are receiving the right kind of appropriate treatment and care. I mean, I was talking to someone who's working within one of our community mental health teams yesterday, and just to assure people, they are very much trying to balance the needs of people who are in the higher risk brackets to make sure those for whom actually they need to see someone, that we're still delivering face-to-face care where we can do so safely appropriate to risk. These are difficult decisions. There's no hard science to it, but the teams are out there across our physical and mental health care services, whether inpatient or community. They're doing everything they can to support people through this very difficult. Thank you very much for all their efforts, and I'm happy to take questions.
Thank you very much, Matthew. Really good report with some really heartening stories in there as well, and clearly outlining the huge challenges that everyone's continuing to face. Are there any questions for Matthew at all? I can't see anything raised at the moment. If not, so thanks ever so much, Matthew. That's really good report. Thank you. If we can move on to Ian, if Ian's off the floor, to come and give us the his report, please. Thank you.
Thanks very much, Andy, and good morning, everyone. So as Matthew's already outlined, the pandemic continues to occupy our minds in terms of service delivery, particularly with the resurgence of it since the end of December. It's certainly having a significant impact on the local health and social care economy, particularly our acute colleagues. And I think that's been very well covered on kind of national and local media. But what it's meant for Oxleas is that we have had to prioritise our adult community health services to support the Bexley and Greenwich system by both re-engineering the pathway to our intermediate care beds, but also really pushing our home first approach to help with helping with capacity within the acute sector. And I have to say that's working extremely well There's some fantastic system working going on across Bexley and Greenwich, and a lot of effort being put in by colleagues 7 days a week to really help with the flow of discharge from our acute colleagues' beds. But this is difficult because I think certainly at the QEH, as at the end of last week, the majority of the people being treated in the hospital had COVID, and it just really brings home the kind of scale of the challenge at the moment. Having said that, across our other service lines, we're continuing to deliver services on a business as usual basis. However, myself and other exec colleagues met with the directorates at the beginning of this week to review their business continuity plans, so that we have a level of confidence that if they have to be invoked, that the correct thinking has been put into this, particularly learning the lessons from the first wave of the pandemic. And it was really helpful, I think, to hear from directorates about how they acknowledged that the way that we approached it last time has had an impact on weights, but they shared ideas, particularly in children and young people services, how they would look to try and prioritise certain services to kind of alleviate the pressure on waiting times. Matthew's already talked about how COVID has been impacting on our staff. As he says, as of yesterday, we had close to 160 colleagues off with COVID-related absence, of which around 60 were individuals who were COVID or are COVID positive. Similarly, the impact on our inpatient numbers has started to creep up. Again, as of yesterday, we had 49 inpatients across our mental health and intermediate care beds who were COVID positive. And we've had particularly significant numbers of COVID positive patients, both within intermediate care, some of which is by design, but also in a couple of our mental health wards, Goddington and Holbrook. And that, again, puts, and I'll talk a bit more about this in a moment, puts pressure on our beds, our mental health beds in particular. In prisons across all our sites, we currently have 87 COVID positive prisoners. So that's across London and Kent. So as I've said, in terms of the bed numbers, the number of inpatients, we have had to take a decision to close some of our wards for admission temporarily. However, we are trying to mitigate the impact in our of this in our mental health beds through the use of the Priory contract and, if necessary, private beds outside of that. And I think Matthew's already covered the vaccination programme, so I won't say any more about that. So that's COVID. In terms of the performance report, the couple of things I just wanted to highlight, and there is quite a lot of detail within the operational report itself. The first is around beds. So in terms of intermediate care bed usage, as part of our work with the rest of the system, we are trying to maximise the potential of those intermediate care beds, and we've really seen an increase in occupancy across both sites. Elton is being used explicitly as a COVID positive pathway. However, we do have cases of COVID at both sites. But the beds in both units are pretty much full as we speak. In terms of our mental health performance, obviously we have 2 wards that remain closed. As we've discussed at the previous board, we have contracted extra capacity with the Priory that is now being utilised. And it's been utilised well. We've working quite closely with the Priory to make sure that that pathway works, and we've had to re-engineer it slightly so that it takes only male admissions, because that's where our pressure has been over the last month or so. In terms of demand for mental health beds, it's been steady, but I think it's been manageable, and again, that's thanks to the collective efforts of a number of people. in terms of decision making around admission, but also ensuring that we have good flow through our beds. And we actually ran a mental health MAID event within our wards last week just to look at how flow is going. The other thing I just wanted to highlight, because it comes up thematically through the performance report, but also the board report itself, is around weights. All of the directorates have got significant programmes of work underway to address weights which have been affected by the pandemic. These are ongoing, and we're obviously keeping them under review as we experience this resurgence of the pandemic. So I think a focus on weight will continue to be a theme for the next 6 months or so. And then finally, just to highlight a couple of items from the narrative report. Just continuing with the conversation around weights. I just wanted to highlight that within our children and young people services, a lot of focus is being put on our ASD and ADHD assessments. And there is a fairly robust plan in place, which anticipates that our weights will be back to pre-COVID levels by the summer, dependent on how this kind of current situation plays out. And this is through a combination of having extra staffing, putting on additional clinics, plus also changing the way that we undertake assessments. So we have found a way of conducting some of the assessments online, and we are testing that out. But the initial feedback from clinicians is that this seems to be working extremely well. Also sticking with our children and young people directorates, and I think this was a question raised by Governor colleagues. We are on course to transfer the Greenwich health visiting contract at the end of March. We're keeping the current service under close review. As has been reported previously, we have had some significant absences within the service. I have to say that has positively improved over the last few weeks, with staff returning from longer term sick, plus the engagement of agency staff. So the service is managing well at the moment. And then the final thing to highlight was in our prison services. The colleagues will be aware that there's some tendering activity underway at the moment. So the Kent Prisons tender is out. The timescale for the submission of the return has now been extended by 2 weeks, which is helpful. And in agreement with Andy, we're in the process of arranging 2 sessions for non-exec colleagues to review the content of the submission with the directorate ahead of the date of the return. And then the other thing to say around prison tenders is that the Gatwick Immigration Removal Centre tender is now live, and it has a fairly similar timescale in terms of the return of the submission. But the directorate is underway with putting that return together. And again, there is the offer there to non-exec colleagues to participate in a review of the submission. So I'll finish there. I'm very happy to take any questions.
Thanks very much, Ian. Stephen Dewar, please.
Thanks, Andy, and thanks, Ian, for first of all a very detailed report, and secondly, I'm sure we all feel the same. But congratulations to you and all the staff in just the most incredibly difficult environment we've ever seen, and hopefully we won't be seeing it again. If I can run together just 3 questions. First of all, sticking with the COVID agenda. Page 52, you refer to where we're talking there of the PPE risks, and they're all coming up green. So my first question is, from a real-time point of view, is that still the situation on equipment? I'll keep running through the questions if you don't mind, probably easier. Secondly, in a way it's minor, but in another way it's more significant, and if he might want to comment on the communications and use of video calls from doctors. So when we talk about the digital transformation And as you signaled before, most of the change has been, in fact, with telephone calls. I'm really, really surprised. It's not our fault, but I'm just surprised that the level of video calls, although it's increased, remains incredibly low. And apart from, I think it would be the CYP. So I would just be interested in your reflections on that. Is there anything we can do about it? I only raise it because in terms of making a step change, I think in our productivity, that is such an important area. And for the patient in 2030, by then, you know, at the end of this decade, we know that generation, that's what they will want to use. So is there anything more we can do to generate more activity there? Because I think the digital data at the moment is a bit deceptive. We probably initially were, from their point of view, were thinking it shows videos working, but of course as more has come through, it's all about the telephone. And then my third, and maybe in a way it's the most important, Bet's ward, which you know, has had a difficult 12 months. I'm a little bit concerned about it. I'd like your thoughts on, are we seeing any improvement there? I know there have been staffing issues and we got some new staff in. The body worn cameras, there's been some resistance to that. Given the difficulties in the ward, can we make the use of body worn cameras obligatory, or can we be a little bit more encouraging for people to have it? And I know Lorraine is off at the moment, but I think it would be a good idea to have a NED virtual visit to Bet's ward as soon as we can be arranged. It was in the process of being arranged, but I think with Lorraine off, it's a bit of limbo. So 3 questions there together. Sorry for the long talk. PPE risks, use of video calls, which is important or not, whichever way you want to look at it. And but I'd be very interested on the Bet's ward one. That does worry me. Thanks.
Okay, thanks, Steve. So in terms of PPE, yes, that still remains green. There are no issues with supply or distribution. So yeah, that's fine, and it's something that we review throughout the week. We have touch points several times a week, so we keep that well under review. In terms of the digital transformation, I mean, I think it's an interesting point, and it is something that's preoccupying my thoughts, particularly within adult mental health, but perhaps for reasons which are different to yours. So I think you're right to challenge us around our use of technology. I think if you look at the report, as you say, there's quite a high reliance on telephone contact if it's not face to face. I think the reasons for that are kind of multiple. I think there's an ongoing one around this concept of digital poverty, which takes has kind of several kind of aspects to it. So it's people's ability to access equipment, Wi-Fi, the environment they're living in, etc. But also, I think it's also perhaps reflective of our staff's confidence with use of that technology. I certainly wouldn't want to generalise, but we have a slightly younger workforce within our CYP teams, and obviously a younger cohort of patients. And I think the level of comfort with using technology is perhaps, or confidence in using technology is slightly higher. So I think we need to challenge that. The thing that's preoccupying me, however, within our adult mental health is that after the first wave, we did transfer a lot of our face-to-face contact to virtual, telephone and kind of videoing, and that's something that I think has led for some of our service users to a less than satisfactory input from our teams, and I think it has contributed to the rising levels of admission, because I think we're not always having face-to-face contact with the people that actually need them. So I think there is something about, if we are using virtual contacts, trying to push the video contact, as you say. But I also think there's a much more fundamental conversation to be had about making sure that we use that appropriately. And there's no doubt that for some of our service users, there isn't a substitute for going out and seeing them within the community in their own environment to pick up on signs of relapse. And that's certainly been a big feature of mine and Ife's conversation with the directorates earlier this week when we were thinking about their business continuity plans. So I think this is something that would be really interesting to come back to through the committees, actually. And then the last point, which was around Bex Ward. I mean, not, as you're aware, Steve, because I think you joined the Bromley operational review, there's quite a lot of detail that sits behind this plan. It is concerning that we've had a high number of complaints on the ward. As is outlined in the report, there's a from my point of view, fairly robust plan in place. In terms of the body-worn cameras, I mean, there is an expectation that they are worn. I think there are guidelines around how they're deployed and in what situation, which I think still allows for some discretion. And I think that's something that perhaps we can revisit to ensure that they are being used appropriately. You're quite right to raise the body-worn cameras, because I think part of the reasons why service users like it is because it gives them greater assurance around the contacts they are having with staff, and it should help in kind of understanding when complaints take place and what that's about, because often they are related to staff attitude and behaviour. So we can certainly kind of strengthen that part of the action plan, and very, very happy for you or any other NED colleagues to join a virtual visit to the ward. I think that would be very, very helpful. I mean, although this is something that we need to get on top of, there is also something about the tone of that conversation with staff. These are challenging environments, as we all know, and often it's the challenge which leads sometimes to a kind of blunting of emotional effect, if I can say that, with our staff, and they become desensitized, I think, to some of the ways that those interactions are taking place. So yeah, we need to be supportive, but at the same time get them to take this very seriously.
Thank you, Ian. Jo, please.
Thank you. Just a couple of quick points. Firstly, the work that the Adult Learning Disability Directorate are doing in terms of working with data and with the CCG on physical health checks and physical conditions for our service users, I just think is excellent work. And, I think we need to continue to maintain what I see as a leadership position in learning disability. Certainly when I sit at Mortality Committee, it is frustrating to see that despite sort of lots of national messages about this, we aren't yet denting the difference in life expectancy for that cohort compared to the general population. So I think that's excellent work. And the other comment I just wish to make was, through the update on Bexley, I think there's a common theme that where we've agreed that we can have some more staff in teams, we are really struggling to recruit that staff, and it seems to be particularly pointed in Bexley. So I guess, to my mind, at the moment, life is very, very difficult, but in a post-COVID world, I think we need to think even more creatively about how we might manage to look at those vacancies. So I just want to make those comments.
Thanks very much, Jo. And just on that first point, I think Lorraine, in her position as Service Director for ALD, has actually been given a bit of a platform within South East London in terms of leadership. And there is now a group, a provider group of kind of specialists for specialist ALD, and I think that will really help in kind of promoting the work that we're doing locally and hopefully transferring that to other providers as well. And you're absolutely right to highlight Bexley. Going back to where we are at the moment, they are the most challenged directorate, I think, both in terms of kind of underlying vacancies, but also how COVID is impacting on the staff group. We've got particular challenges, I think, in Bexley. Yeah.
Yeah, thanks very much, Ian. One of the questions Sue brought up was around any impact of COVID on the mental health of local people. Sue, did you want to expand on that question at all, to Sauter?
I'm having fun with my computer this morning, and my neighbour started to drill in the wall, so I had to move. That's all I need. Yes, it's just obviously looking at all the news. Mental health is a big problem at the moment, not just amongst your clients, but also about staff. And it was just how is this impacting on us as a trust, or you as a trust, and us as a trust? And how do you see this moving forward? Because the last thing we want is the staff to go down, but also the increase on what is likely to be the number of patients you will have to see in the future, given everything we see in the news at the moment.
Yeah, I mean, it's a really good question, Sue. I mean, in terms of staff, I think we're constantly checking out through various routes how we can best support their mental well-being. I think there are a number of opportunities that we have to keep in touch with them. There's quite a lot of targeted work going on at the moment, particularly with our managers, because they are often the kind of group of people who are trying to kind of contain and support other staff. So we're trying to help them, if you like, and Rachel might want to say a bit more about that. In terms of the impact on kind of generally on the population's mental health, I think there's no doubt that both COVID and the restrictions that result from that are having a negative impact on people's mental health and resilience. And I noticed it started to be highlighted a lot more in the media. Locally, there are some quite interesting initiatives going on. So in Greenwich, there is a wellbeing hub that was established in the first wave and is continuing now, and it's managed by Charlton Athletic, who are one of our partners. And I've had a conversation with them recently that the number of calls into them is going up quite significantly. And people who don't have a kind of underlying mental illness, who are clearly finding the situation very, very difficult. And in actual fact, we're offering clinical supervision to the people manning the lines there. But in terms of how that's then translated into pressure on our services, I think a lot of that is filtered through general practice and primary care. So they are probably soaking up quite a lot of that demand. But we have had some kind of short-term investment put into the kind of local system, which is targeted at services outside of Oxleas, which I think is very helpful, because I think it is general practice and also the third sector who are probably best placed to pick up this demand, because in essence we remain a mental illness service, and to treat people with kind of mental illness, and obviously what we're talking about is a general deterioration in people's mental ill health, which is completely understandable, but it's not necessarily related to an illness process. So I think it is about how we have a leadership role in helping the rest of the system to work together to try and meet this demand. But I'm not sure that there's a kind of an easy fix. But hopefully you've kind of got a sense of some of the things that we are doing. Rachel, I can see wants to go.
Can I just follow up quickly on that point, if you don't mind, before Rachel kicks in? The government amounts, there was some funding for mental health. Will Oxleas be able to tap into any of that?
Yeah, I mean, some of the funding I've just alluded to, Sue, has come down through the ICS to spend outside of Oxleas, but to support people appropriately in, kind of further upstream, if you like, so that their situation doesn't deteriorate, so they need Oxleas. So I think there's money in the short term that is being worked up into a plan and being deployed. I think if that works, then that creates a really strong argument for ongoing funding going forward. So yeah, I'm hopeful that will happen.
Shall I speak very briefly about your important point about staff wellbeing? And Ian's mentioned some of the issues, and I think it needs to be our central priority at the moment. We know that sickness levels are higher than they usually are, but they're perhaps lower than some of our peers. But nevertheless, I think the pressures on our managers in particular have never been greater than they are at the moment. We spent quite a lot of time at executive listening sessions over the last couple of months, really listening to the experiences of our staff and our managers on the ground to try and work out what would help them the most. What's clear is that it's not just the challenges of trying to keep the show on the road in terms of the services and trying to make sure you've got the right staff in the right place at the right time, although that's a real challenge at the moment. It's also the fact that we've got very vulnerable staff, we've got staff who are shielding, we've got people who are experiencing lots of bereavement and anxiety outside of work. And so I think that kind of pastoral side of the manager role is greater than it's ever been. So we're trying to do what we can to try and build people's resilience, give them some chance to kind of speak to each other, and also to try and give some chance for people to have a bit of fun, to disengage a little bit from some of the stresses of the work. So there are no easy answers to this, but it is something that we're really focusing on.
Well, thank you very much indeed, Rachel. Thank you, Ian, for a really good report. Rachel, I'll move back to you, please, now on item 7 on values and behavioural framework. Thank you.
Thanks very much. So board colleagues and others will have seen many iterations of these values over the last few months. And I'm pleased to be presenting to you today the version that we want to agree and launch over the next month. So just a reminder that the values and the behaviours have been designed in response to direct feedback from our next step strategy engagement work. People told us they didn't like our old values. They wanted something much more memorable and that spoke to the heart of Oxleas. We also had important and moving feedback as part of our discussions around building a fairer Oxleas, around Black Lives Matter, and around all of the discussions around how we best tackle bullying and harassment. And we wanted feedback from those important discussions to play a central part. We've tried to achieve that in this document. So we set about creating values that were a bit different, that spoke equally to our interactions with patients and carers and visitors, but also to our interactions with each other as staff members. We deliberately didn't want to capture every behaviour that could be considered to be a good thing, because I think that's the trap that some organisations fall, and then you end up with a very long list that no one can remember. We've also been really clear that our values and behaviours are designed to supplement, not supplant, our professional standards, our policies and our strategic priorities. But most of all, we wanted values and behaviours that anyone in Oxleas could demonstrate, whatever their role, whatever their band and whatever their location, and that they could remember. So we've undertaken significant engagement with teams, with our networks, with staff partnership, with patient groups. And I've got to say, I've been really impressed by both the quality and the quantity of the feedback that we've received. People have had great ideas about how we simplify it, how we make it more streamlined, and how we make it more impactful. And we've taken as many of their ideas on board as we can in this final version. But most of all, it's been really heartening to hear the positivity and the enthusiasm that people have shown about these values. And I'd particularly highlight the warmth that the nursing group have demonstrated. If you haven't been on social media and seen the songs that they've created about our new values and behaviours, then you're definitely missing out. But it's been really heartening to see that. But we've had equally good feedback from the medics at the MAC and also from our shadow executive yesterday. The days are all going into one. Earlier in the week, I think it was. They were really keen that we pressed ahead with this and really made it happen. So once adopted, the next steps will be for us to be rolling these out over the next month. We want to have discussions in local teams, but we also want to really recognise the pressure that people are under at the moment. We don't want these discussions to add to people's pressures. We want it to help, and we want to start with our focus on kindness. And then there'll be a really big programme of work to embed these values and behaviours in all of our people processes, so in our recruitment, in our appraisals, in all that we do. We want these values and behaviours to be things that run through Oxleas like words on a stick of rocks, where they really want to speak to the heart of Oxleas. Finally, I just wanted to thank everyone on this call, our non-executive directors and executive directors alike, for the support that you've provided to this. I know we've discussed it on lots of occasions, but I've been really grateful for your input, and I hope you're happy with where these have got to. And I'm now looking for your approval for them to be adopted and for us to roll them out. Thank you.
Thank you. Done on leading this. Stephen Dilworth's got a question. Steve.
Thanks, Andy, and thanks, Rachel. I mean, I think it's an excellent document, and I think you've done really well in the current environment to keep this under our profile, because I think for a lot of organisations it would be too easy to forget this now. But as you said before, it touches on our real culture, so it's such an important thing going forward. I was really pleased as well about page 83. You've got in some measurements there, because I sometimes think in the past on this sort of project we haven't always been very good at measuring things, but you've got it in there. My comment is a tiny small one. Apart from that, on Appendix 1, page 85, you've just got a phrase there about "we will not dismiss people." And I think you mean in the sense of we will not disrespect them or ignore their feelings, as opposed to someone in extraordinary circumstances who does something very bad. We could let them go or dismiss them in that sense. So if you just want to check out on that phrase, as I say, it's page 85. But apart from that, I thought it was really good.
You're absolutely right in that interpretation, Steve. Thank you.
Thanks very much. Nina, please.
Completely echo what Steve has said. I think this is, again, another piece of a very thoughtful, very respectfully driven work. And my only question is around the operational side of things. We talk about implementing it or beginning on the journey between February and April of this year. There's obviously a big question mark around where we're going to be from a pandemic perspective. I know in organisations that I've worked in before, as much as the ground is ripe for change, people may not respond to that change if it's delivered at a point at which they are just exhausted and trying to survive. Have we got a plan that just takes that into account so that we're not losing the enormous impact of the work?
Can I respond to that, Andy? So yes, absolutely. So the very last thing I want to do is, with my enthusiasm for this bit of work, is to go in with big boots and kind of try and dominate lots of meetings. What we want to do, and there has been actually quite a hunger for people wanting to know that they've been adopted because they've wanted to discuss them at away days and things, is for us to go to existing meetings, so not to be putting on new events, but to go to existing meetings, to talk about them, to talk about how people can very gently start using them and start exploring what they mean. But I do see that this rollout period is going to be a more prolonged one than it might be in a different context. And this is going to be very much the start of hopefully a snowballing process where we embed them in everything. But what we don't want to do is to say we've got a pandemic, values and behaviours don't matter, we will revisit that in May, but it's a very gentle start to that rollout process that we're envisaging at the moment.
Thanks, Rachel. That's anything from everybody else. I want to reiterate my thanks. I think it's a terrific piece of work. It's really, gets to the heart of what we're trying to do, and a really good opportunity, I think, to launch a whole range of different behaviours, I think, across the organisation. So thanks for your leadership in all of this. It's been really, really good. Well done. Thank you. We'll move on now to item 8, CQC. Iffy, please.
Thank you, Chair. Board members will no doubt remember that over the last several months, we've had a number of CQC focused inspections, the outcomes of which we've already shared and discussed. So the paper in front of you is the final report from the inspection of both Scarborough and Shepherd Leys wards that was undertaken by CQC on the 7th of October. You will know already that we were served a warning notice on account of 3 things. One is they found that we hadn't adequately assessed ligature points on Scarborough. The second was that we didn't have clear mitigation plans to reduce the risks that were attendant to those ligature points at both Scarborough and Shepherdley's, our two older adult wards. And the third was a lack of clarity at several levels about who is really responsible for implementing action from SIs. As a result of this, the ratings for the older adult service line has dropped from good to inadequate, and that's simply because they rated safety as inadequate and well-led as inadequate. But the trust overall rating as an organization remains good. And as you would have read, as you see in the paper, we've made some progress in putting together action plans and trying to drive change with additional and consistent support, both from our facilities and management colleagues, but also an additional nurse that we've put in to support ward managers and clinical teams to get on top of the assessment and understand the ligatures and also be very clear in their minds about how to mitigate those. So I feel fairly confident that we will meet the 8th of February deadline that the CQC have given us, when we intend to provide them with the evidence of what we have done so far. Going forward, therefore, I think we have already started, I know we've already started visits to those wards. Vicky was there yesterday with a number of colleagues, and will also be there next week. So these are visits quite apart from improving lives visits. We will be discussing progress of the action plan we've put in place for this particular inspection report, but the other ones too, at our monthly meeting of the exec. And for this particular piece of work, there is now a monthly ligature management group that's been established, and the meeting was held only just yesterday. And of course, in the usual way, CQC regulatory updates, including actions and how we're doing, will come to PQAC, subcommittee of the board, and from there we'll come back to the board in due course for assurance. That's all I wanted to say, Andy. Happy to take questions.
Any questions from colleagues on this at all? If not, Suzanne, please. Thank you.
It wasn't a question, actually. It's just a comment to add to the actions that IFE has reported. We've also asked for the report from the monthly ligature management group to come to the infrastructure committee as well, just so that we're confident that we're covering things both from the clinical and environmental perspective. And IFE and Vicky have shared with me the action plan, which has more detail than here. I felt that the action plan very effectively identified who was going to be responsible for what, which I think is absolutely key with this, and what the timescales were.
Thanks, Suzanne. That's very reassuring. Yemisi, please.
Thanks, Chair. It was just to echo what IFE said, that PQAC will be monitoring this to ensure that all the aspects that CQC have raised are dealt with, and dealt with properly, and not just from a responsive point of view, but that we put structures in place to make sure that they don't recur again. We will be looking at the risk assessments that were done and how it appears on our risk register, making sure we've captured every mitigation element to make sure that we do give a full response to the CQC and assurance to the board. Thank you.
Thanks, Yemisi. I lost you slightly at the end, but I think we got that, but I'm grateful for that. Sue Salter, please.
Yeah, I did send in a question about this, but thank you very much for the update. That was beneficial to hear what's going on. and also from Yenith about how you're going to put this into your risk management program. So you should get a fairly frequent report about that. But I suppose one of the concerns or queries is actually encouraging staff to be quite aware of that and reporting it, because risks are very good, but it is reliant on the staff involved or anyone involved actually informing you that there has been an issue or an accident, if you like, and it's making sure that is ongoing, because that's the thing that encourages improvement and ensures that you're meeting the requirements, especially in the light of the CQC report. And thank you.
Thanks, Sue. And Rachel, did you have your hand up? No. Okay. All right. Thanks very much. Yeah. Thanks very much, then, Iffy. I'm very grateful for that report. We'll receive updates, no doubt, in due course. If we can move on now to item 9, which is the serious incident report with Azra, please.
Thank you, Chair. I'm going to assume that everybody's read the papers, but I'll just briefly summarise the incident that we were investigating as a panel, and just to say that both Sue and Steve Dilworth were involved as part and parcel of the panel that was investigating this. So this was a very unfortunate incident that resulted in an infant dying from non-accidental injuries. The actual focus of the Oxleas inquiry, however, was concentrating on the mother of the child, who was actually under a treatment programme with Oxleas at the time of the incident. There is a separate investigation that is taking place in regards to the death of the infant, and we did have to be careful during the course of the panel investigation not to stray into those areas. And also, it did mean that we weren't able to normally speak to the people that we would have done, that was the support network of CH, because that was not considered appropriate given the circumstances of the child's death. The panel had effectively looked through the details of CHS's interactions with Oxleas. This was the second time that CH had actually been subject to Oxleas services. The last time had also been around perinatal access with the birth of her first child, and then this was the second referral, both for perinatal services, but actually coming closer towards the birth of the child to our PCP services around some consideration of her own actual mental health, irrespective of the birth of the child. CH did have a suspected diagnosis of autism, and the incidents that occurred in the middle of the very strict first lockdown that we had, which did mean that we had suspended face-to-face. So picking up Ian's point, this was done very much as virtual interactions in terms of all of the areas. It was a fairly complicated case, because the family had moved probably about 6 times over the course of the last 2 years, and there were multiple boroughs that were involved and multiple teams within those boroughs that were involved. So it was a fairly complicated process in being able to establish what the background was, and also to actually ensure some of the interactions that we needed in between all of those teams in regards to both CH's own social worker and then also the social workers for the children to be able to properly access the full complexity of services. The outcome of the investigation was that there was no root cause identified, and we did explore quite heavily as a panel what the impact was of the digital access versus if we had actually had CH come in to have a face-to-face interaction at the hospital. At the time, they were all suspended, and therefore that had not taken place. The findings then, in terms of the key recommendations, I'm just going to finish the summary, and I know Steve does want to come in, so perhaps once I've finished that summary. There was a lack of clarity from perinatal services on the referral to treatment time. So I think there was guidance in place that talked about an outcome being presented 2 weeks after the first referral letter. And there was a real discrepancy between the service believing that that was 2 weeks after the referral to say that the individual had been accepted into the perinatal services and had then been given an appointment, versus the individual actually having had an interaction with a clinician in terms of that outcome. So that was really the first recommendation that we had, is we needed to clarify that element and make sure that it was in line with national requirements. And that probably takes care of both the lack of clarity and the appointments not being offered in a timely manner. There was felt to be a lack of joint working within Oxleas. So as I'd indicated, CH was originally brought in, originally referred for a perinatal appointment and interaction, but then there was also a PCP interaction due to the fact that there was a threat of suicide that had occurred at one point. And the panel felt that there was not sufficient interaction between the two teams in terms of handover and really discussing the details of the case. So although everything was articulated within the case history, there wasn't necessarily the picking up of the phone to talk to another clinician about all of those aspects and to ensure that the handoff occurred. So for example, on the PCP element, there was a belief that there did need to be an interaction and an appointment, but because there was a booked appointment with the perinatal services, that was effectively the outcome measure that was used in terms of the next clinician interaction with CH. There was felt to be a lack of joint working between external agencies. Now, I have to say that was not due, to lack of trying of certainly the CH clinician that dealt with the perinatal aspects. There was multiple evidence of the fact that that clinician had tried to access and speak to external agencies. But because of the issue that it had come across boroughs, because of the fact that we were probably in a pandemic at the time and we had lockdown, those responses were not necessarily coming forward in a timely manner. But there was real evidence in regards to the history of this particular case that the clinician did repeatedly try to get that information through. There was an issue with contemporaneous note keeping. So although people had met with CH and had then completed the paperwork, what there wasn't was a reference that was contemporaneous with that initial meeting to guide any future clinicians that were looking at that case of the full detail of the interaction that had happened with the clinician. So we wanted to raise that as a point. The safeguarding children documentation was not completed as it should have been within this case. And so there was clarification of that element. And it was also felt by some of the clinicians on the panel that there was a lack of professional curiosity demonstrated. So that ability to say certain interactions were turned down by the client. There was a reluctance to use video conferencing, even though this was not about digital property. That individual had access to that, but had actually asked for telephone services, and certain interactions that were less than ideal, I would say, in terms of having the full scope of availability for those clinicians to be able to make a decision. And lastly, there was something about the consideration of the equality impact of video calls with somebody for autism. So the individual had actually said they felt very uncomfortable having a video conference, and they did not like that functionality, so preferred a telephone call to video interaction. The individual did have a face-to-face appointment, but unfortunately that occurred after the death of the infant, and therefore we didn't have a face-to-face interaction until that point of time. The recommendations are all then articulated along with the action plan within the paperwork and effectively addressed those elements of the process. And I think do cover off most of the areas. Principally, it is around ensuring that we have got the proper protocols in place and that there is a reminder sent to all of the staff of the processes that they need to follow. I can see that both Sue and Steve have their hands up, so I'm just wondering whether or not they wanted to come in and expand on anything that I have said. I think it was Steve first and then Sue.
You okay for me to go, Andy?
Yes, please, Stephen.
Yeah, thanks, Ezra. This has been a troublesome inquiry. There's no doubt about it. I'm also mindful of the fact that in sort of those final conclusions, we've had the COVID going on, and it's been over a Christmas break. And a bit like Suzanne Shale, I only got to read the whole papers yesterday, Wednesday. And Ezra, you quite rightly touched on sort of the absence of good record keeping, the problems with multi-agencies, etc. Where I'm having great difficulty with all that Oxleas and everyone else has done on it, and it does touch on policies, service standards, training. The assessment at the PCP, well, one of the panel members described it as, I won't use her entire phrase, but inadequate. And I think it was, whether that's training or not, whatever. I think given the patient's background, there was probably I don't think we've touched on it in that recent summary, but I think there was too much belief in what the patient was saying when there was a lot of other evidence, you know, she'd be saying I'm fine and my relationship with my partner's fine. And there was a lot of evidence that that wasn't the case. So probably we were a bit too naive, perhaps, in believing all that. At the assessment level through the multi-agency approach, I think it should have been referred to the home treatment team, but it didn't meet with the threshold, I'm quoting, didn't meet with the threshold for intervention. Also, as the report stated, proactive safeguarding was not implemented. So I think it's right that we pause now to reflect in the board, because I think there will be, quite rightly, a lot of challenges on this. I think it is debatable, the conclusions we've reached. I know I don't want to preempt what Sue's going to say, but I know Sue, as we were discussing this through the months of the panel, had a lot of similar feelings to myself, that just the discomfort that we'd done everything we could. CH, by the way, it was referred to us on the 26th of May, and the actual appointment, after, you know, a very difficult background, it was clear that she was in a crisis. And in fact, the appointment was made for the 19th of June. Now, in fairness, that was within the service standards. So you can take a view that that's all we can offer. But I think for many of us, there was this feeling that that was just too late, that CH needed support prior to that date. And so you had that challenge of sort of budget overriding responsibilities, basically driving service standards, and the fact that the service standard didn't meet the need in this particular case. So it's not an easy one, but I guess I don't feel happy with where we've got to. And I'd be interested to see if Sue feels the same. So I'll pass you straight to Sue.
Thanks. Is that okay, Chair, if I carry on now?
Yes, please, Sue.
Thanks. Well, I echo everything that Stephen said as well. Obviously, it was a hard and difficult case to look at, and anything involving mental health and the outcome for the child was very sad. But I do think that there were failures, if you like, and I hate it's a strong word, but somewhere along the line, as responsible trusts, the royal we, it needs to be looked at, are the policies right? I know you can't cover every case. I know that from my own involvement in the NHS. You can only make policies and protocols to fit what is a common occurrence, if you like. But sometimes not every case fits the criteria. And should there be a way of jumping the gun and making the referral quicker? And certainly, I think we were all surprised on the panel about the 2-week gap. We thought that might be reasonable, but in these, there are some cases when it is too long. The other thing I think, which Steve touched on, is the poor communication across the multiple healthcare organisations. And I know that's difficult, having worked in the health service and worked in an area where we were bounded by 3 or 4 different different organisations. But at the bottom and in the centre of this must be the people we're looking after. And there mustn't be any, well, sorry, that's my patch, that's your patch. We should be putting the people we're looking at and caring for in the middle of it all. That has to underlie everything we do across the NHS, whatever speciality it is. And I think the other thing that hit me, well, a lot of it hit me with my background, but certainly the one thing that I found interesting, and I know it's commented on in the report, is the lack of follow-up for the DNA, because it wasn't a normal, DNA did not attend, because it was a phone call or video. And should they be treated the same as a physical failure to attend, with a follow-up? Certainly in my experience in my profession, if somebody didn't turn up for an appointment, we were either on the phone to them or we knocked on their door, either that same day or within 24 hours, to make sure everything was okay. And I appreciate it's COVID and all that, and I think COVID caused all sorts of upset across the NHS, but I do think we can learn from this and move on for the benefit of the people we care for and their families, and also the staff involved, because we mustn't forget the impact on the staff. I think, but it was a very difficult case, and I think sadly at the bottom of all of this was communication, and that's usually one of the things that comes out in many investigations, and it's a way how we improve it. And again, the royal we, because obviously I think every one of us needs to ensure that the service that's offered is the best we can get. I'll shut up at that point. Thank you.
Thank you, Sue. Thanks very much for all your work you've done on this inquiry. We'll come to Suzanne next, please.
Thank you, Chair. I've partly got a question, and it would be helpful if Azra would like to respond to that. And I don't know, Azra, whether you got my email prior to the meeting, but I did try to contact you beforehand to say that I was going to raise this question. And apologies if that was too late. My question is about why no root cause was identified. And I have a difficulty with this because the purpose of the investigation is for us to learn as a trust how to improve our systems. And if we don't identify a root cause, we can't know that our recommendations relate to the underlying causes. And I just wanted to give a definition of a root cause, because this is not the first investigation report which has come to the board saying that there hasn't been a root cause identified. So what we're looking for is the earliest point at which action could have been taken to strengthen the support system for appropriate care to be delivered, to avert the cause of the incident, to prevent its occurrence, or to significantly reduce its impact or occurrence. And if I were to look at the recommendations which you've put as a group, those recommendations all seem to me to be suggesting that there was not sufficiently robust and rigorous planning behind the setting up of this service, and the fact that it was the service is in operation without a service operational policy having been completed and finalised and signed off raises grave concerns for me, because we saw very similar problems with the PAS inquiry, where there was not a finalised full proper operational policy. And the reason I want to emphasise this in terms of how we look at this as a trust is that if it's the case that we've seen in this service that we've got a service running without an up-to-date operational policy, and clearly without adequate pathways having been identified in terms of our relationship with with the other agencies, then I think the kind of confusion that has arisen is almost inevitable. And it's a confusion which we would see in other services which have similarly complex relationships with multiple agencies. And that's the thing which worries me, because this service is not unique in having very complex relationships with a number of other agencies, all of which have to work well if we're going to discharge our responsibility to patients and those around them. So I'd be interested to hear your kind of comment on that, but also to understand why there was a view that we couldn't identify any root causes, but we've nevertheless made recommendations.
So thank you for that. I'm afraid I didn't manage to get your email before, Suzanne, because I was in a set of meetings and doing some other elements, but I think you've articulated what the questions and concerns you have in detail. I think firstly, it's just picking up the key areas that we did actually cover off in the interviews that we had with the members of staff when we were going through it. So we specifically explored, did they feel, and we explored it kind of quite heavily with everybody, the fact that we were doing that as a virtual appointment and the fact that we were doing it in the middle of the first wave and lockdown of COVID, did they feel there was a direct relationship in regards to the treatment that they offered at that time versus what they feel that they would have had they engaged on a face-to-face appointment? And I think the issue was, because of the way that CH presented, and this included feedback that we had obtained from her social worker about the interactions that they had had over a long period of time with CH and the observations that they had seen of the family interactions, we couldn't get to a direct conclusion that said the fact that a face-to-face appointment had not been offered had actually impacted directly on what we felt on what the outcome was within that area. We had a very long and protracted set of discussions around the timeliness of the appointment and also about the interaction that we'd had between the PCP, which was triggered by the initial referral about the fact that there had been a possible suicide attempt, and then the second interaction in regards to perinatal. Now, in all of those cases, I think it comes back to the points that Steve and Sue had made about a lack of communication. The service had insisted they already had procedures in place, but those procedures needed to be strengthened. So in recognition of some of the areas that we were looking at, they said that they were going to go out and relook at the protocol. The key concern that we had is that one of the interviews that we had, because of the timing of when this incident occurred and the first referral arrived, and when the service was delivered and the timing of that during COVID, there had been some verbal handover of individuals going into services where they had not had what we felt was appropriate training. Now, that was one of the areas that we wanted written documentation listed down. So instead of it being a verbal handover to somebody about exactly how they would triage, we wanted that written down. Lastly, and this really comes back to the core point, why we didn't identify root cause, is I did actually get some advice from, well, effectively it was within Jane's team, and Jane, I can see, has got her hand up, so may want to come in on this piece, because I directly asked, right, would we normally say that this has root cause analysis? So this may be down to the fact that this is the first board level inquiry that I've actually undertaken. As both Steve and Sue stated, it was actually a very, very difficult case to go through, and I did have quite a lot of discussions with both Caroline Stroud, who was advising in terms of this and how we would normally treat it, and I did do an email exchange and have a conversation with Jane about whether or not this would be an appropriate outcome. So that may not quite answer your question, which is why I'm thinking it would be really appropriate if Jane came in on this point.
Jane, please. Thank you.
Thank you, Zara. I just wanted to make a comment that it's incredibly difficult under the current NHS Serious Incident Framework of 2015 to actually find a root cause analysis, even though that's the methodology we're requested to use. Because in doing the systems-based inquiry, we're looking at the what, which is the problem, the why, which are contributory factors, and there may be several contributory factors. And then we go to the how, sorry, the why is the root cause, the how is the contributory factors. But under the new patient safety incident response framework, which is the new methodology, the 5 whys and the root cause analysis has been removed because the new framework wants to move to a much more reflective, continuous learning rather than a framework of accountability. And within this, it is encouraging people to use that systems-based investigation, but also to look at causal factors, but to look at human factors as well. And the root cause analysis, so that why did it happen, is less important in the overall, so long as the learning is much more explicit and we can get recommendations out of it. I think from our own experiences, particularly in Oxleas and particularly in mental health, it's incredibly difficult to actually find one root cause analysis, and there are often many different contributory factors which interplay into this. And I think Azara is right, this is possibly one of the hardest investigations that I think we've had for a long time. And on the panel there was some experts, including Dr. Livia Matusi, who's a consultant perinatal psychiatrist from SLAM, and we had obviously safeguarding expertise on it as well. And I think for people who are very used to dealing with the ambiguity of perinatal mental health and safeguarding, even they found this incredibly difficult. And I believe there is going to be, from the Safeguarding Children's Partnership, a likely learning review or a Safeguarding Children's review. And I'd be really interested, when we look at all the information that different partners across the system have that could have been put together, whether we will get similar learning from this. So this isn't the only inquiry and this isn't the only outcome and learning for us at all. But I think we just have to take a caution about the root cause methodology and try to move to the new systems-based methodology as quickly as possible. I hope that helps, Azara.
That's really helpful, thank you. And I think just the last point to pick up, which was I'd had my hand raised initially, was I think we did recognise that during the first lockdown, we did go to virtual because that was the advice that we'd been given. And just really coming back to the point that Ian has made, I think we have over that period of time said that is not the correct approach to use. It has to be on an individual case-by-case basis. And if we truly feel that it needs to be a face-to-face appointment, that has to be the appointment that is raised. We've done quite a lot of work within the teams to reinforce that particular principle, and also made sure, as Ian had said, that when we've gone through the business continuity piece, that we're also reflecting on the fact that we must look at those on a case-by-case basis.
Thanks, Ezra. Matthew.
Thanks, Andy. I mean, slightly setting aside this case, sorry if my signal's a bit poor, I'm on the Wi-Fi here, but setting aside this case, I think the problem is when we say no root cause, it kind of sounds slippery, especially when you have so many things that have obviously not worked properly. And I mean, I've sent back 1 or 2 RCAs internally recently because I've looked at them and I've thought, well, I suppose I'm probably in the repeatedly asking why mode that Suzanne's alluded to here. But you know, you go back to a point, and with some of the cases, you think, had we done this differently, would it have stopped it happening? Now, it is always very hard to find the thing that would have changed the outcome. And I think, you know, there's been a number of our SIs where I've been quite happy to say there's no root cause, because you look at it and you think, do you know what? There's some things we could have done better there. I don't think it would materially change the outcome. But I think there are other cases where you look at the number of issues we've picked up and the number of recommendations and say, are we really saying there's nothing we could have done differently? And I think we get into this tough area where we're saying we think there's a range of things we could have done differently, and yet none of those things individually was the root cause of the incident. There were a bunch of factors that made it very messy and they weren't ideal. And, you know, this is problematic because I suspect if you went across the entire NHS on any given day and pulled out the records of any person who was receiving care over a period of time from the NHS in any sector, you would find things that hadn't been done in accordance with policy. You would find records that hadn't been completed entirely in accordance with policy, and you'd find things that had been done by staff that hadn't been written down but had been done as well. And when you go into an SI and really go into the details, you find all this other stuff that raises all these questions for you. So I think this is a really tough one, because certainly when I saw the range of the recommendations and I saw no root cause, you think, are we sure really? that we can identify this many shortcomings in the way a service has been designed, and yet say in the terms of this case there was no root cause. Probably under the guidance as Jane set out, actually that's the point you reach, but it doesn't feel satisfying, because it doesn't feel satisfying to see this range of concerns and still say, you know, at heart, poor communications and planning were, you know, a really important part of what went wrong here. You know, so I'll probably open more questions than answers, but I know we as a group discussed this repeatedly as a board, and also within the exec we have some really robust discussions around this. And it might be one for a strategy session for us to spend a bit more time looking into some of the policy and context around this, not necessarily in the context of this case, but for us as a board to make sure that we're all at least recognise what we're talking about when we talk about root cause analysis and the methodology behind it, because it's a very important part of what we do, because we need to acknowledge where we've got things wrong and learn from them. And I think sometimes saying no root cause feels as though we're being evasive in that space.
Thanks, Matthew. Jane?
I was just going to agree. I think that's a really good explanation, Matthew. Thank you.
Thank you, Jane. Stephen, please.
Yeah, thanks, Andy. I mean, that's a very good summary from Matthew in terms of where the kind of systems may take us and what you actually feel. And Joe's raised the question quite rightly in the chat room. So would I and Sue Salter agree with the final conclusions? And in fairness to Ezra, because the month of December was when a lot of the staff meetings took place, and I know I couldn't make them, so Ezra has a benefit there. But nevertheless, I've only seen the final conclusions as of yesterday. So in answer to the question raised, no, I don't feel comfortable with it, to be honest. I think the way out of it, to get some sort of clarity rather than just having an oral discussion, might be to have in writing from Jane and the advisors within Oxleas as to why they don't feel the root cause analysis is appropriate, that there isn't a cause within the system as it's laid out. I think, as Suzanne's pointed out about the absence of policies, and I think as for Sue and I, certainly there's this whole thing about the PCP triage, you know, that single point, I think did make it, well, it did make a difference. I don't think there's any doubt about that. There's the lack of flexibility and communications, which is this very broad area, which Matthew touched on. But again, undoubtedly that made a difference. And I think it would be just good for us all to pause and reflect with something in writing, which says this is why we don't think it's appropriate to have a root cause, and then we would reply to that with perhaps Matthew and or Andy as perhaps an arbiter on that at the end of the day. But I think it's going to be difficult for us to reach an approval on this today. That's my feeling.
Thanks, Stephen. I'll come to Sue and then Suzanne, if I may. Sue Salter, please.
Can I just, it's Sue here. Can I just support what Steve was saying? Obviously, I've read it. I did have comments way back and shared some with Steve at the same time and with the chair for the investigation. I'm not entirely comfortable, but I think Steve's suggestion could be a way forward and see how we end up when we've got that, because it is important that everyone feels happy, if not comfortable, with the recommendations as any investigation, because that has to be the way forward for Oxleas Trust, and to look at the recommendations. I don't know. No, that's my view at the moment, and I'd be happy to go with the majority of those that are on the panel with me.
Thank you, Sue. Suzanne, please.
Thank you, Chair. I just wanted to make 3 points. One is that I think it's really important that we come back to the purpose for which we're doing this, which is to understand whether our systems are optimal in terms of keeping our patients and others from harm, amongst other things. So, you know, to echo what Jane has said, this whether it's a root cause analysis or a different kind of inquiry, is focused on understanding our systems systems and whether or not they need attention in terms of preventing this kind of thing from happening again. And, you know, when I say this kind of thing, no two incidents are ever identical. You know, they're always different. And so what, you know, we need to kind of understand that, you know, how we need to look at this at a systemic level. My second point is that there's a root cause analysis does not require you to find a single root cause. That's not the point of it. It's to find root causes, plural. And if I look at the recommendations which have been made, those suggest to me some underlying root causes. And my third point is, is that this is Oxleas has been, in a previous homicide review, there has been comment that Oxleas has identified that there's not a root cause. And the reviewer has said, if we look at what happened here, to us, the root cause was changes in Oxleas service pathways, which put this this pair of people at risk. And I think that there was a recommendation then associated with that, and that recommendation was to the effect that if we changed our pathways, we needed to be really clear about the policies that supported a change in pathway. And that was why I was particularly focused here on looking at the fact that when this service was set up, perhaps the right pathways were not put in place. I mean, I wasn't part of the panel, so I have limited insight into this. But as I say, I think that the question for us has got to be, we run a lot of services which are very complex, which require us to engage with lots of other agencies, which are all under pressure. So the question is, do we have systems in place which facilitate that happening? And I think that this, the serious incident should be an opportunity for us to ask that question and to set about answering it.
Yeah, thank you, Suzanne. This is some really good points here. I mean, Matthew, did you want to capture anything here?
Yeah, I mean, I think we need to have a bit of a look into why this has come here when there's members of the panel unhappy with it in the state it's in. So I think we need to take this away again. And I would say in terms of some of the work we need to do, we could do with a bit of time on this. Certainly, most of the patient safety team and others are redeployed at the minute due to COVID. I'm not saying that to say that we don't need to do this, but we could just do with a bit of time rather than a rapid turnaround to make sure we do this in the depth that's required as well. We should take it back through the exec and have another look at the panel's contributions to it, whether we managed to get all the right people to take part in it, and then do the broader piece to discuss how we're approaching root cause analysis. But I would see that as something we should endeavour to do over the course of the next over the course of months rather than weeks, given where our patient safety resources and where people like Jane and others are spending their time at the minute.
Yeah, thank you, Matthew. Clearly, there are recommendations to take forward here. So there's the recommendations that we've got to deal with, and then there's the broader question around root cause analysis and how we deal with these things anyway. So I mean, our colleagues content with this way forward. We refer this back to the executive to bring it back in due course on there. And what I really don't want to do, I think there's been a huge amount of work that's gone into this in what I think is a really complex and very difficult inquiry. So there's no criticism whatsoever. This is really difficult. And having seen some of the variations in root cause analysis training and things such as that, there's a number of different ways to approach this. But I think, as Suzanne has said, the idea of this is to make things better, isn't it? I think I'm paraphrasing rather more simply than you said, Suzanne. But again, I don't want to miss the fact that I think this has been an awful lot of work gone into it. But we've got to capture the lessons here, and we've also got to capture how we do things into the future. The MSc, do you want to come in at this point?
Yes, really briefly. Whilst I agree with the discussions, I just wanted to point out that nobody seems to necessarily disagree with the actions required as they're stated. And if we're going to take it away and then bring it back in a couple of months, does that put into jeopardy maybe some of the things that we need to do immediately? that maybe we do need to implement sooner rather than later?
Yeah, that was one of my worries, actually, that you know, there's no reason why the recommendation shouldn't be taken forward, so nothing's going to stop. Jane, I'm looking at you on. I take it we're going to be taking this forward, but we clearly need to review this and review how we do it. Jane?
Yeah, definitely. I think everybody's pretty clear on the findings and the recommendations that are laid out in terms of actions and learning that can be taken forward immediately. And some of these are already well under progress within the action plan. So my recommendation would be to carry on with that and make sure those fundamental systems and processes are put in place and that learning's taken forward. And in the meantime, the serious incident team and the panel can reconvene to look at how they want to articulate the contributory factors or root cause analysis in light of the conversation that we've just had, if that's satisfactory to everybody.
If that's satisfactory for everybody, we'll move forward on that. I'm hugely conscious of the massive workload that you, Jane, and in particular, but an awful lot of the other people are going through right now. So it's got to be in the context of everything that everybody else has got on their plate. But clearly, we need to do this. So we need to carry forward the recommendations we've got, and review how we do these things, and then bring this back to the board. I mean, is everyone happy with that way forward? If so, I want to thank you for and Azra. You know, this is a really, really tough one, but I think you did a superb job there, Suzanne.
I just wanted actually to echo the point that you've made actually about how busy people are. I mean, some trusts are not pursuing their systems analyses, in the way that we are. You know, they're not investigating serious incidents. As a trust, we've kept this up throughout COVID, and we've continued to attempt to respond and to do these inquiries with video interviews and all the rest of it. That is not easy, and I think this is a challenging investigation at the best of times, and this was hardly the best of times. So I would want to just kind of echo that. I think that people have endeavoured to do as good at, have really tried to do a good job under some quite difficult circumstances.
Yeah, absolutely. So Azra and Stephen and Sue, thank you very much. Rory, I think has Simon's joined us, hasn't he? Simon McCrory. But I'm proposing that we have a break of 10 minutes, if we can, at this stage, which would take us through to 12:17. Is that okay with everybody? And then we'll come back, we'll jump down the agenda, and we'll go to the freedom to speak up at that time. Okay, thank you. And I know you're aware of a big, busy schedule we have today. Thank you.
Thanks, Andy. It cut out a little bit there, but if I just introduce very briefly, I'm delighted to welcome Simon McCrory on behalf of the Guardian Service. As everyone knows, the Guardian Service provide the Freedom to Speak Up Guardian role for us in Oxleas, and they were appointed in January of last year. And we had been due to hear from Lincoln Murray, but he's very sadly had to go for an emergency operation at short notice. So we're very grateful to have Simon stepping in on his behalf at short notice. Now, I know Simon will speak very briefly to the paper because I know you'll all have read it. It sets out the detail of their activity and their recommendations from the first year of operation. And I'd just like to take this opportunity, if I may, to just say how well I think it is going with the Guardian Service. I think the flow of information both ways is excellent. And Lincoln, Lulu and Junan meet with us regularly to explore themes and ideas for improvement. And I know that Steve James isn't here today, but he does meet with them regularly too and wants to feedback that he thinks it's working well. So over to you, Simon, but I know you want to spend most of your time answering people's questions, but thank you.
Well, good morning or good afternoon, everybody, as it is now, and Happy New Year to everybody. Yes, I think I would echo Rachel's words that I believe the service has worked as well as could be expected in the first 12 months, particularly in light of the pandemic. And it has actually restricted us in terms of on-site presentations and on-site presence as such. And hopefully as soon as possible, we'll be able to address that issue as we go forward. I think it's important to note that in terms of your overall numbers, in terms of the contacts made with the Guardians in the first year, 60 or in the first year, 69, should I say, in the 12 months, that is on a par with other mental health trusts. And I think that's reflected in the document for you. It's often a question raised by client trusts as to, you know, why are the numbers as they are and could they be higher or should they be lower indeed? And it's a very difficult question to answer. The reality is that people come forward because they see us as one other option. We're not the only way that people can speak up in your organisation, obviously. You have a very interesting culture. I know my experiences of working with you in the early days when we commissioned the service, I found it really engaging. And I actually said to people afterwards, I noted how friendly it was in that people stopped and spoke to each other and people did engage with each other in the corridor. You wouldn't always see that. And I think that's also reflected in the way, overall, in terms of how you work with your staff. But with numbers of 4,000 people, you're always going to have issues, you're always going to have concerns. And the Guardians provide that one other option for individuals to speak up. Your themes equally are representative of what's happening across the country in terms of the NGO data. So the fact that you have fully 1/3 of your concerns relate to bullying and harassment, that would be on a par with what's happening across the marketplace. Probably Rachel and Matthew know about my particular views on bullying and harassment, and I have some fairly hard-held views about that issue. But nonetheless, many times when people come to us with a concern which they call bullying and harassment, actually when you break it down, it relates more to communication and relates more to behaviours. And if those can be unwound quickly, well, then it can be put to bed and put to rest. So again, the Guardians are very attuned to that and would always challenge those kind of claims. And we do see ourselves, by the way, as your Guardians for your staff, but equally as Guardians for you and for the leadership of the organisation. And that we don't want to see unwarranted or indeed even malicious claims being made against people, because that is not healthy from anybody's point of view. So we do challenge. Overall, I think it has gone as well as we could have expected. I would like to think in the year ahead we can find more innovative ways to communicate if we are restricted in terms of going on site. But there's a lot being done in that space regardless, and I know you're doing a lot of work yourselves. But I will be talking to the Guardians in terms of how do we up the ante, as they say, and how do we get in front of more people on a more regular basis. And yeah, so that's where I would see the recommendations we've made back to you. Unlike a number of other trusts, I have to say, you do take them on board and you do address them. And I wouldn't say that every trust that we work with has the same rigorous approach to dealing with the concerns that we raise, and indeed in dealing with the overall recommendations we've made. And so if you look at the recommendations at the end of the report, you will note that there is progress probably on all of them in terms of the various different initiatives being taken by the trust at this point in time. That's about as much as I have to say. In a summary, I'm happy to deal with any questions you may have.
Thank you very much indeed, Simon. Nina, please.
Hi, Simon. I'm Nina. I'm chair of the Workforce Committee. Thank you. That was a really helpful summary. I'm going to start, if I may, with a question which is just an extension of the very helpful comparison that you did with our peer group. I've heard, and it's very helpful to have the context in terms of the number of cases and the themes. My specific question was around how do we compare to peers as regards the reason that people make contact. I found it quite striking that if we combine them together, there's about 30% that don't go direct because of a fear of losing their career or losing their job or reprisal. And then there's about 45% who believe they won't be listened to. And just interesting in terms of cultural indicators, how our peers do on that front. What I might do, just because we're on Teams, is go with the couple of other questions as well. When I see on pages 3 and 4, I think it was, the tables where there are some trusts that have 0 patient safety or 0 bullying and harassment, my natural instinct is to struggle to accept those numbers because I think the NHS is incredibly complex. We do some very complex stuff with some very complex groups of people. So I don't know whether that natural instinct is the right one or whether I'm wrong. We should actually be aspiring to 0 in both of those categories. Interested in your views on that. And lastly, I just wondered if we could hear from the exec briefly, please, on the recommendations, particularly as regards the Datix issue and prisons. Thank you.
Thanks, Dina. Before we go to the exec, I'll ask Yemisi to come in, please. Yemisi, did you have your hand up?
Oh, yes. Thanks, Andy. Yes, in fact, my question was very similar to Nina's first question, and it refers to the table on page 164, because I think I interpreted it the same way Nina did, in the sense that the first 3 reasons why people use the service go to reprisal or an example of, whereas the last 3 reasons almost go to reasons around inertia, that the system and the organisation won't do anything about their concerns. And it's interesting from our data that if we could collectively, 31% use reprisal as the reason, cite reprisal as the reason, whereas 69% cite inertia as the reason. And I just wanted to know whether Simon had a view on that. Based on these numbers, what does it say about our organisation, if anything, or is the sample size too small? Thanks.
Yeah,
okay.
Simon.
Yeah, to the...
Simon, you're on mute.
You know what? I was actually on and turned myself off, right? Sorry about that. To the issues of why people use the service, I think first and foremost, you're absolutely correct. Sample sizes can be deceiving here. However, I would say across our client base, we would see similar figures. If we were to put them all together and analyze them, the figures would be relatively the same and would have a consistency about them. A lot of these issues ultimately are perceptionally driven. So you can't actually look at them and say they're facts. You have to accept that they are people's perceptions of the world that they actually live and exist in. So even when people talk about fear of damage to career, that may well be something that they perceive has happened to another person who raised the concern, but they actually don't know what really happened and they don't know what that outcome was, but the perception remains with them. And so that might be a reason why they wouldn't speak up. I would say the greatest number, the highest number of reasons given to us would be that people believe they just don't be listened to. And that is reflective of just staff-held beliefs. Staff can have strange notions that build up over time. I mean, if you think about, I won't be listened to, and then at the same time, I've gone in on site into various different trusts to promote the service. And even after 4 and 5 years, I'd walk up to a nurse's station and say, who I am, and have you heard of the Guardian Service? Nope, never heard of you. And we've been promoting for 5 or 6 years. So people hear about these things and will react to them when they need to. And it is a question we always ask, because we're always interested to know why are they coming to the Guardian Service so that we can report it to you. But it's difficult to know whether that's a reflection of your culture or not at this point in time. If fear of reprisal and fear of damage to your careers was much higher, I would have a concern, because it would indicate that there was something happening, there was a dynamic taking place, and people were aware of it. But it's not, and I wouldn't be concerned in terms of how those figures stack up. Does that answer the question for people, or would you like to know more? Yeah, okay.
No, that's fine, thank you. Sorry.
I love the question, should we aspire towards zero for patient safety issues? Of course we should aspire towards zero, but I think you're absolutely correct, is that the complexity of the NHS will always lead to issues emerging that we have to pay attention to. So as to why some trusts are reporting zero patient safety issues, well, one has to understand and appreciate that the nature of freedom to speak up in all of these organisations is quite unique and quite different. So depending on the actual emphasis placed on it by the organisation, you place a considerable emphasis on it. And you listen and you hear and you want to interact with your guardians. We have to fight hard in some other organisations to be heard. And we have to constantly remind them of the contractual obligations that we hold in terms of getting this particular service provided to them. You also have the situation where you have internal guardians, and we've always been of the opinion that internal guardians are compromised from the day that they're appointed. It's either tacked onto their job, and they are giving it a certain amount of time, maybe an hour a week or a day a week, whatever it may be. But also, you know, in many cases, and I don't mean this in a disparaging sense, but a Band 7 nurse is not going to take the CEO on and face them down if there's an issue. They're just not going to do it. And you can understand why, and we can fully appreciate it. Whereas, hopefully it hasn't happened yet, Matt, but our guardians will face you down. They will come. And I mean, I had a wonderful conversation during commissioning with some of your teams where, and I think it's worth recounting, where one of the leaders or one of the managers said to me in front of their peer group, they said, well, you know, I can be very busy, so if you send me an email, I mightn't see it, and I mightn't have time to respond to it. And my response to that was, I said, don't worry at all. We will send you an email. I said, if you don't respond to that, we'll phone you. And if that doesn't work, Lincoln will turn up and be standing at the foot of your desk, and he won't go away till the issue's dealt with, because that's our job. So have no fears. We will hunt you down, as they say. And that's the job of a guardian. And we do have that. We are in the fortunate position, whilst we have enormous respect for you as an organisation, we don't have to respect the hierarchy. And that allows us to actually wind our way through the organisation to get resolutions and solutions where it's appropriate. And I think both Lincoln and Lulu are well skilled in that, and they're not aggressive in the way they do it, but they will be persistent. They're terriers with a bone. Once the issue is on the table in front of them, they will stay with it until they get the answer. So as aspiring to zero, I don't think we should always aspire to zero patient complaints, quite evidently. But I think you're absolutely right. It is questionable, those organisations that are returning a zero return on that particular area, and probably reflects more the environment in which people are operating in, and also in terms of the strength of the freedom to speak up environment that they've established. So I would say never, the bottom line is that you want to hear what you need to hear in an organisation. You always want to hear it. You mightn't like it, but you want to hear it, and you want to be able to deal with it. And that's the purpose here. And I think there always will be patient safety issues. It's inevitable. We're humans, and therefore, the quicker we can react to them, the better. Does that comprehensively answer your concern, Nina?
Thank you, Simon. If I could just come over, sorry, if I could just, before I come to the exec, I want to go to Suzanne, please. Thank you.
Thank you, Chair. I had two questions, actually. One is around the patient safety cases, because I think this is quite an interesting one for me, in terms of whether or not people are raising patient safety issues with us because they've exhausted other avenues of raising them and haven't got a response. Because I think that sort of trying to figure out how many we should have or how many we shouldn't is not terribly helpful. But what I think that we should understand is how responsive we are to our staff when they raise raised patient safety issues with us. So I don't know if you can give us any insight into the kind of background of why it was then that these cases were brought to the Guardian. And my other question actually related to the recommendations. I wasn't quite clear why there was a recommendation around making people more aware of what the probation issues were, or what the probation policy was. So perhaps you could, I think Rachel's got a hand up there. So
I will defer to Rachel on the probation issue, that's fine. In respect of the patient safety issues, there's a variation of a theme here in terms of how and why people come to the Guardian service. I'll pick one as an example. There was a COVID issue brought to us in, I think, about March or April. And the individual who brought it to us was rather concerned about how patients with dementia were being allowed to basically amble through the ward that they were located in, and that there wasn't, in her opinion, sufficient safeguards in place in terms of the transmission of the virus should any of them have been infected. So she raised the concern, and she was reluctant to raise it to her boss, who was also her supervisor, and so on and so forth. She raised the concern, but actually what had transpired was that, having raised it to the Guardian service, and I believe Lincoln dealt with it, it was an issue where communication had not been sufficient in informing this individual that the correct steps were being taken. They took the view that they were being countermanded when they shut down the ward, basically, and corralled it, and they were overruled because sufficient procedures were in place, but that individual wasn't aware of them. So in that situation, it was more so an issue of misunderstood communication as to the protocols. They raised it as a patient safety issue. We immediately flagged it as a red alert, as we will do with any patient safety issue. And then, therefore, from there, it was actually resolved. They will come to us because sometimes in raising a patient safety issue, there is a considerable amount of finger pointing involved, and basically somebody is being blamed for something that's happened. And very often they want to speak to a guardian, talk through, is that principle of I need to hear what I say before I know what I think. And they want to talk it out with the guardian before they would take it any further. Sometimes they take it directly to consultation with the guardian, other times the guardian will raise it on their behalf. So it is the nature of them that people are reluctant because they know an individual is going to be compromised the minute they bring it up. Does that help, Suzanne?
Yes, it did. And I think that, you know, for me, the value of reading the Guardian's report is trying to get a handle on the extent to which we have an internal speaking up culture in which people do feel confident to raise patient safety issues, and you know whether there are areas where our systems are not providing an avenue, apart from yourselves, to do that. So I think I'll just sort of take that one away and think about it.
I would suggest you're better than most.
Thank you. If I want to go to Nina, and then I'll come back to Rachel and Matthew to finish off. Thank you.
Just a follow-up question, if I may say, Simon. We've talked about issues being resolved, and the report refers to 6 out of 7 issues being resolved. Who determines that they've been resolved satisfactorily?
It's in essence, it's the individual who's raised the concern. It says, I'm happy with that outcome.
And that's through the engagement that they have with you. So they right. Okay. Thanks.
Nina, I think it's really important to recognise that we don't want to create formal upset in the organisation. So when a guardian takes a concern, their first thoughts are, how do I get this resolved pragmatically and effectively before it spirals out of control? So often they will approach the person's manager or the manager's manager. They'll enter into that discussion. They'll figure it out with those individuals, and it's put to bed. That stops it going into the formal process, and it takes the stress and pressure off the staff member, because it may even be that they had emotionally created a concern in their minds that actually wasn't really there, but having had the conversations with their manager or with the guardian, they recognise it isn't what they thought it was, and they're happy. To us, that's an absolutely excellent outcome, rather than it being formally acknowledged, oh, we had a concern, we went through a process, and now, etc., etc. Interestingly, the current research we're involved with is looking at the cost of formal grievances in the organisation, conservatively estimated at about £45,000 per grievance when it's raised. And that's just your formal systems. That's long before lawyers get involved or tribunals or anything like that. So we are very interested to try and establish and tie that figure down. That's anecdotal, I must admit, but I don't think it's too far off the mark based on the preliminary research that we've completed at this stage.
Understood. Thanks very much, Simon.
Welcome.
Thank you, Simon. If we go to Rachel and then to Matthew to finish off, please. Thank you.
Thanks. I can be very brief, Chair. I just wanted to respond to the two specific points of detail that had been asked about the recommendations, and given that Simon stepped in on Lincoln's behalf, I think I'm a little bit closer to those. So on the first one, which was around datix and how in Belmarsh the speed of responses to what are being logged on datix. The concern is that sometimes it can feel to staff that they log these issues and then they don't get the follow-up as quickly as they might. The management have looked into it. They feel that that is a fair criticism, and it's something that they're really keen about tackling, because that makes sure that the right support is in place for our staff. So Michelle Storer has taken that on, and she will be making clear to Lawrence Mack when he starts in February that that's a real priority there too. So they're really on that and trying to fix it. Secondly, around probation policy, it came to us that people weren't clear exactly what our probation policy was and how it kicked in, and we're just going to improve how we communicate that to our managers. So that's something we're very ready to take on board.
Thank you, Rachel. Matthew, please.
In first place, thanks to Simon and his team, because they've been fantastic to work with in this, and it's great to have them at Oxleas. I think it's really improved the way in which we're managing these issues. So, notwithstanding that, the great work that our internal guardians have been doing for us over a number of years, but Simon and his team's really helped us rise to the next level, I think. And I was just interested in a couple of things. One is the people raising concerns that their things won't be acted on. I mean, I've been at CQC and been on the other end of these. Sometimes it's a genuine concern because someone has rightly raised a problem and it hasn't been acted upon. And sometimes it's someone's raised a concern and it's not been acted upon in the way that they would like. And as a result, they've tried to take another route to it. And I remember particularly fondly a sort of case that was presented to me as a major piece of whistleblowing from a trust, and it was actually largely to do with a group of staff who were very unhappy with rota changes and the impact it had on other aspects of their lives. And it was an entirely sensible series of rota changes that were actually strengthening the quality of the service. And yet, because the management had sort of said, look, we're not prepared to do this, it was felt that whistleblowing was the right route for it. And I think some of what the Guardian Service does is it provides us with a robust, independent voice to say, actually, do you know what? This isn't genuine whistleblowing. This is something you need to go back and talk to your team managers about. And it's really helpful, I think, that they're not seen as partisan within Oxleas when they're given that kind of sensible feedback. And I think it's an asset for us that, as Simon says in his slightly Liam Neeson-ish way there, they will hunt us down if we're not doing the right things there. But, equally, they can offer that challenge back to the staff as well and say, look, this is not a legitimate whistleblowing concern. And the other thing about patient safety is, if an organisation reports an increase in patient safety, they say our culture's improving. If they report a decrease, they say their culture's improving. It's kind of difficult. It's about the context of the individual context. I think what's useful is to benchmark ourselves, and the Guardian's oversight across a range of organisations allows us to do that benchmarking. I think if you ever get to a situation you've got 0 complaints coming through, I'd be really worried about that. And to be quite honest, it's either probably because you've got no patience or because people are terrified or don't know how to raise concerns. So I think some measure of reporting the concerns is a sign of a healthy culture within an organisation, but you really need an organisational capacity to go under the skin of these to understand the context, and that's very much what the Guardian Service has really been able to build up with us. So thanks to Simon, to his team, to Rachel and the team for doing this, and also thanks to Wendy and Sally and others who've been working really hard on this within Oxleas for a number of years now.
Yeah, thank you, Matthew. And Simon, was there a last comment from yourself?
Yes, just thank you. Just in respect of Matthew's comments there, and the 0 patient safety issues, it's well worth looking at the TED talk from Amy Edmondson from Harvard, who did her research on psychological safety in respect of the number of prescription error rates per 100 bed days in a hospital. The teams that reported higher prescription error rates were the teams that were much more effective and much more innovative than the teams who didn't. It was something that she talks about quite eloquently because it confused her in the early days of her research. She thought the opposite would be true, but actually it turned out to be the other way around. Just something that might be worth looking at. She's readily available on her TEDx talk. That's all.
Simon, thank you very much for that. I think that was really, really good report, and very grateful for the work you're doing for us. And thank you very much indeed. So thank you.
Thank you very much.
Move on. Thank you. If we can move on now to mental health annual report from Jane, please. Thanks.
Thank you very much. This is the annual report for 2019-20, and it has been to the Mental Health Legislation Oversight Group and also to PQAC. And this gives a summary of our use of the Mental Health Act and the Mental Capacity Act, and allows us as a board to meet our obligations and duties. Before I go over the headlines, I just want to say the whole ethos is on least restrictive practice. And although there has been some analysis of the data, what is really interesting is the observations that it makes, rather than us being able to actually deduce any causal effects or reasons for why there are fluctuations each year. So to start with, the highlight is there's been a decreased usage of the Mental Health Act. So we've seen this in terms of our own data, but also anecdotally for other trusts in London and the South. And the greatest decrease is in the Section 5.2s. These are down 35%, and the Section 136, which is down 25%. Now, whilst it's difficult to say there's a cause and effect, we do know that there has been an awful lot of work over the last few years looking at the crisis pathway. There have been a number of new initiatives that have come to fruition and have started to become very embedded. And I've listed some of them in my cover sheet, but things like the SIM project, the Sun groups, the CAT cars. And also we've had changes to our own health-based place of safety, with it being closed for a period of time at Greenwich last year, and then the Bromley one shutting so that the new state-of-the-art one at Oxleas House could open. But that may not be telling us the whole picture. In terms of the reduction in the Section 5.2s, which are used on informal patients, there isn't really any obvious cause for this. It may, however, be related to the lower number of informal admissions we're having, and also about the turnover and an increased length of stay for detained patients, given the opportunity for this section being reduced. In the analysis of the data, there's been some look at repeated detentions, and it seems to show that there is a greater emphasis on using Section 2 rather than Section 3. Again, we look at this in the context of least restrictive practice, but it is being explored and it is being looked at. It's the first year we've got this data, so we'll be interested to see what this trend tells us, if it tells us anything at all. Lisa Moylan, the head of mental health legislation, has been looking at whether this is about changing practices of the approved mental health professionals, or whether it could be about the doctors doing the assessments and how well they know the patients, and that they're opting for the least restrictive options. And then finally, I'd just like to draw on ethnicity. We look at this every year, and on a positive note, we have increase the recordings, so there are fewer patients and service users with no ethnicity recorded, but we still have the pattern of white patients are detained at a lower rate. This is a common finding across London, and an awful lot of work has been going on for a long time around community engagement, community development to help address this. But more recently, the Trust Equality and Human Rights Group has arranged for each directorate to produce their own action plan to look at how they're addressing all sorts of equality factors, but they are all focusing very much on the ethnicity data and trying to increase access and improve equity and fairness. So we should see some feedback from those plans through the Equality and Human Rights Group over the next year. I won't go through the rest of it, but the areas that we will focus on over the coming year is the ethnicity recording, as I've said, continuing to monitor the Section 132 and the Section 58 compliance. And we will be required to implement the liberty protection safeguards when they come into force in 2022. And we'd like to look at gathering more meaningful data, which at the moment we pull from RIO and IFOX. But the Mental Health Legislation Oversight Group is keen to actually look at that in a lot more detail at the moment under Lisa's leadership. Thank you.
Thanks very much, Jane. Stephen Dilworth, please.
Thanks, Andy, and thanks, Jane, for a very detailed report. You touched on section 132, so I know I've asked the question before of yourself and Iffy, so forgive me asking again. And I realise on a month-by-month basis, it's small scale. We vary from 92 to 99%. It'd be so nice to get that at 100% consistency, wouldn't it? I just wonder if I compare it to the police, which Andy will know. You know, if they're charging someone with something, that's just automatically done in the process. Am I being a bit naive here that can we not get it to that stage that's just automatically done and we see the magical 100% figure? And as I say, I know I've asked before, I ask again.
Yes, and I think the mental health administrators and Lisa are working really hard with the clinicians within the teams to try to make sure this happens. They've put in some practical ways to address this using the whiteboards on the wards. The numbers are very small, so therefore if there is a deviation in compliance, it has a larger impact. But you're absolutely right to raise it. It's a really important area. Consent to treatment and information on rights is absolutely paramount to our patient care, so we do need to strive for that 100%.
Thank you, Jane. If I can go to Joe first and then I come to Iffy, please. Thank you.
Thanks, Andy. Thanks, Jane. I think the ethnicity point is really interesting, and to my mind, you know, we have some opportunities with the way things are going in the ICS and things like that to really start looking at some of this data, because I suspect the detention rates is just the tip of the iceberg, and you get into things like access to services and such like. And I think it's something we should absolutely be working with our partners in the ICS and the SLP to look at, and actually then working with commissioners to see how we can actually change services to ensure better equality of access. So I'd be very interested to see where those action plans go and who we're involving them. Thank you.
Yeah, thanks very much, Joe. Iffy, please.
I was just going to add to Jane's response that certainly the numbers are small. That does contribute to the challenge, but also we find sometimes with those few cases who are placed on community treatment orders that quite apart from being given the information whilst they're in hospital, they need to get the information from their community worker when they get into the community, and sometimes that's where we drop the ball. But every effort is being made to ensure that people are reminded, chased up, and I think that if we can use what we pull out of RIO to improve performance, that would be great.
Yeah, thanks very much, and thanks, Jane. I think the things really seem to be developing well here, and we're getting some really good quality information. So I'm very grateful for your efforts on that part. We'll move on now, please, to QI, and that's you, Iffy, I think.
Thank you, Chair. So I'm going to assume that colleagues have read the report. I don't know, Sally, are my slides going to be put up, or will I just... so I've got just a handful of slides to help colleagues as we walk through the report. I shouldn't spend more than 4 or 5 minutes. So colleagues will recall, particularly members of the business committee, that we started our QI program in 2018, after a period of real debate and challenge, which was very helpful as it helped us to be quite clear about what we are likely to get out of the program. The team was in place by July, so we've been running now for 2.5 years. We've got a number of QI leads, obviously constrained by money, if money wasn't an issue, I think we ought to have more than 4, perhaps 6, one for each service directorate. But you see in the paper how we've divided up the work for the QI leads. Next slide. So at the outset, particularly when we're contemplating using getting support from IHI, we decided to adopt their dosing formula, which is what you set out in terms of how you want to successfully implement your QI, and training was fundamental. So as you see from this, at the very top, you want to have 1 or 2 really skilled people who will drive the program, and then right at the bottom, you want to make sure that a lot of your staff are trained, and that's why you see 2,200 staff estimated to receive just the basic training, and then as you work up fewer numbers of staff. By the end of this financial year, we expect that 33% of our staff would have had the training that's relevant to their roles and the work that they do in Oxleas. Next slide. The next slide just shows you where the staff have come from. If you look at the top slide, it's a bit misleading. The second slide, which often causes a lot of debate, a QI committee, as you see, ALD, Bromley and corporate, about 40% of the staff have had training, and the others range from 5 to 20%, 5% in prison services and 20% in Greenwich. Greenwich, of course, has a really large workforce. Next slide. And this slide just shows the projects. We have completed 43 projects and 62 are active. And as you see from the next slide, we try, next slide please, Sally. We try our absolute best to make sure that we keep these projects live through the website. We have an external website that also has resources, information about QI membership, team membership as well. And I'm really grateful to the members of the team who are also very Twitter savvy and repeatedly tweet what good news there are. And also we often go to conferences and present QI, and this is also tweeted and it's available on the website. Next slide. Next slide, thank you. Thinking therefore about how we know that it's the QI, the introduction of QI has made a difference, we decided at the outset that one of the ways of establishing this would be to get feedback from our staff. The 3 graphs you see, the 3 plots you see here show 3 things. One is when staff were asked whether they feel that they're able to show initiative in their role, whether they're able to make suggestions to improve their work, and whether they're able to make improvements happen in their area of work. You see that we were, as a trust, at our best in 2015, and things really seemed to drop from that time onwards, including after we started QI, but we seem to be going back up again, almost to our 2015 levels. Now, I cannot guarantee and I cannot claim that this is entirely as a result of QI, but given that this was a measure that we thought we could use at the outset, I think it's important to just share this as a possible reason for the improvement based on the responses from staff. Next slide. Return on investment is a challenge with QI. But again, borrowing from both the work that East London Foundation Trust have done, along with IHI, these are the 6 areas that most people would agree you could get return, depending on how long QI has been done for and how well. In Oxleas, we think that the bottom 4, we have lots of examples of the benefits with respect to cost avoidance, productivity, staff experience, as I've just shared with you, and perhaps more importantly, outcomes for our service users. And if you read the report, you find in the report some of those examples. Next slide. One of the areas that we've been challenged repeatedly at the QI committee is service user involvement, and we adopted this national Little I's Big I, Little I, where QI have been about service users with some participation. Big I being about co-production with service users, and we continue to ensure that we increase the role service users play. In the last several months, there has been some co-produced QI training, which we expect will support service user involvement. And there's also been some firmer links with volunteering services, which we hope will enable us to bring service users more into the work that we do. The QI committee now also has a couple of service users with lived experience, which I hope, and I think if Amlan was here, he would agree, or Steve, would constantly challenge teams as they present their work to ensure that service users are involved. And next slide, please. And the next steps, therefore, are for us to do, to my mind, 3 or 4 things. One is certainly to make sure that having, over the last 2.5 years, trained staff, encourage people to come up with whatever ideas they think can be subjected to QI to improve service delivery and to improve the quality of care to patients. We now need to try and corral people to undertake QI projects that align with our vision, our strategy, and certainly the things that come out of our quality management framework from the perspective of quality planning. What are the concerns, where are the areas that we seem to struggle with, and we can then encourage our staff, along with services, as to try and tackle those issues. And going forward, of course, we want to spend a bit more time using our quality management framework, which has been to the board and the board strategic day. So I will go over it again to become the vehicle for continuously improving the quality of care that we provide in Oxleas. And that's it. I'm happy to take questions. Thank you. Thank you, Sally.
Stephen, please.
Yeah, thanks, Andy. Thanks, Iffy. I mean, it's great to see the projects that are ongoing. It's very rare that you see something that actually changes the culture of an organisation. So I think it's fantastic to recognise that this is, you've used the phrase embedding a new culture, and that's exactly what it's doing, that continuous improvement throughout the organisation. I'm also great to see that you're trying to analyse and measure some cost benefits there. And again, we said earlier in the meeting today, we don't always see those measurements taking place. And I entirely take what you say. There'll be some things that you can't quite measure, but I think the executive have made a really good job of trying to put some tangible costed benefits on the improvements that have been made. You touched on there, in doing that, we need to be careful about the correlations between the QI activity. I think particularly on page 142, where we've got the one about Atlas House, and then part of the improvement is clearly due to fully staffing, which is noted on the graph. And so, is it the staff that's made the major impact, the fully staffed, or is it the QI project? Any question I want to ask you, do you think, and maybe you could put a percentage on this, would any of these improvements have taken place without the QI program? And if so, do you have a feel for whether that would be 5 or 10% or whatever percentage?
It's a difficult one. So when I look back to perhaps 3 years ago, and certainly at the time we put together a business case, there wasn't much QI taking place in the organization. There were lots of service transformation, service improvement, etc. But not QI in the strict sense of QI. And I think that this program has really helped staff in the organization, and in fact the leadership too, because there has been training for leadership to think about QI, to think about how to use QI methodology to improve things. So there's no question in my mind. You ask for a percentage, I would argue perhaps something on the order of 90% increase in the adoption of QI. And the other thing I need to say is that it's not just about using QI in its full format. You know, we talked about this previously in terms of what QI did we undertake during COVID. People were testing new ideas throughout that period, and that in itself, the concept of if something isn't working, huddle together, think about solutions and test them. If it works, carry on. If it doesn't, drop them and test something else. That's by just training staff and by saying that this is the culture we want in Oxleas, people feel free to adopt and to change and improve things. So those sorts of quick PDSS cycles we may not capture, but I know they're going on. You know, all too often I sit in meetings and I have conversations with people and they're describing stuff to you, and I hear it as QI. They don't necessarily think or talk of it as QI. And so I have no doubt in my mind that the program is making a huge difference. And in spite of everything we're going through, we need to make sure it remains at the center of the way that we deliver care in Oxleas.
Thanks, Iffy. Any more? If there's nothing more on that, thanks very much indeed. Really good report. Great to see the developments have happened within QI, and thank you for you and your team's leadership on all of that. So we'll move on now to item 13, which is PQAC, and Yemisi, please.
Thank you, Chair. A lot of the stuff that we discuss in PQAC has actually already been touched on in greater detail today, whether in Matthew's report, in Ian's report, or in Jane's. So I won't go over those aspects. At our last meeting, I did mention that as well as COVID-related items, we'd also started talking about non-COVID items. So we'd brought the normal agenda back as well. And due to that, we've had to be flexible in PQAC and extend the length of our meetings. But it's good that we can be reactive to the situation on the ground. So in fact, now, because of the current COVID situation, we're now actually going back to just focusing on COVID issues. So our next meeting next week, we will just focus on the COVID aspects. We've already discussed COVID monitoring, and what we try to do in PQAC is to ensure that we're monitoring the up-to-date situation and then getting the relevant members of the exec to try and sort out any problem areas that we pick up. So that's been positive. We had in December, we had the mental health beds review, and that was really good because it allowed us to look at the proposals of shutting the 2 wards and the impact that it was going to have on patient safety, patient care, and the transformative work around patient care. So we had a discussion around that. And we've set up our own monitoring schedule of how we're going to monitor that work going ahead. In terms of providing the board assurance to many of the issues that we consistently talk about in this meeting, so around Section 136 and around restraints, just to let you know that there is active management around those kind of issues. Exec members are involved, whether it be the COOM, whether it be the medical director, ensuring that we try to make sure that the figures are going in the right direction, and that the information is shared with directorates, and that there is active management to ensure that we reduce our restraints and we reduce the 136 breaches. Both in November and December, we had presentations from ALD and forensics. And again, I'd like to say just how well those presentations are going. It did take us a while to embed them into our committee, but they are proving incredibly valuable. And now that directorates are beginning to understand what the committee is looking for in terms of assurance, those are really positive. And finally, I just wanted to mention the Improving Lives programme, which is an extension of the peer review programme that we had before that uses CQC methodology to provide our internal assurance. So we still keep up to date with CQC communication and updates. We get that every single month, and we monitor our responses accordingly. So I didn't want to say anything else, but I am happy to take questions.
Thank you very much indeed, MSc. Stephen Dilworth, please.
MSc, I'm sure I saw it in the paper somewhere, but I don't know where. Did I get it right that the Belmarsh COVID incidence has reduced from 70 plus to 1? And if so, that's a clinical miracle. So how did that happen? If he might want to answer that.
I think Ian's got his hand up at the moment you said it, so he could provide a bit more detail. Ian?
Yeah, no, Steve, it was. I mean, it's a very positive result. I think that reduced over the space of 3 weeks, is my understanding, and the outbreak was contained on one house block. But visiting Belmarsh as I did with Michelle in December and speaking to the governor, as I understand it, it's they have kind of introduced much better infection control procedures. And certainly I observed that amongst prison staff, there was kind of what you'd expect in terms of use of PPE and also access to, hand sanitizer, ventilation, all those sorts of things. So I think they've done a fantastic job. It was a real cause of concern for the Royal Borough of Greenwich, as you can imagine, given that the prison sits in their patch. But yeah, and they're managing to maintain the levels to a reasonable amount at the moment.
Well done, thank you. That's really improvement. Any other questions on PQAC? If not, I'm very grateful for all your work, Ian, and the MSc on that. Much more to report on QI. Iffy, QI committee.
Right, just a few things to point out. I'm going to assume colleagues have read the front sheet as well as the minutes. So the first project that we received, as you see, involved 50 service users, Oxcare. I have no doubt in my mind at all that once we successfully launch this, it will make a huge difference to patients, carers, and certainly our clinicians. The second project is interesting because I think it speaks to Stephen Dilworth's question to me, that just simply saying, let's look at this DNA through QI, they recognize that the issue was people just weren't recording failure to attend properly. Just the whole idea of saying there is a problem here, let's huddle around it and try and deal with it, made a substantial difference. And the third project we looked at, I think is also fascinating in its own. The third presentation from ALD is also fascinating in its own way, because you recall I said 40% of staff have been trained. They've got 5 active projects involving 40 staff. So that's a directorate. It's not a large directorate, I take it, but that's a directorate that's really enthusiastic, where everyone really gets involved. And of course, what we haven't said here is that we also received the QI reports that I presented to you earlier. Happy to take questions.
Thank you, Iffy. MSc, please.
It's just a quick comment, actually, to back up Iffy's report with QI. and Steve Dilworth's questions around the improvements, and are they solely due to QI? Having been on the QI committee since we set it up, there's a definite feel-good factor that I think staff have, the ones that are involved with our QI projects. It seems to have given them a sense of confidence and pride around the things that they've done, which is quite intangible, really. But so I think that's also helped and added to the improvements that we have seen. So, you know, I would advocate we continue to put our resources in this, because there's something that we can't quite quantify, but it's having a beneficial effect. Yeah, thanks.
I'd put it down to really good leadership, that one, the MSc. It seems like from Iffy and the team, I think. There's some real tangible benefits, as you say. If there's nothing else on QI, we go through to Business Committee, please, Jo.
Yeah, again, I'll take the report as read. I've just raised two issues. One is, and it's the first bullet point on the cover sheet, the financial performance is in line with expectations. So you recall we've got a sort of a trajectory to a £1 million surplus. I just want to take a bit of time. I think we've been saying every month, you know, the finances are where we expect them to be. And I'd just like to take a little bit of time out for Azra and her team. There are huge amounts of ups and downs and different factors they are having to take into account. So the fact that we are, you know, where we plan to be is a great result. So I'd just like to acknowledge that there's, you know, when things are as we expect, we don't spend any time on them. But actually, I think, you know, praise where praise is due there. The other thing just to mention, and Ian mentioned it in his operational report, so we've got a big bid coming up with Kent Prisons, because as you know, it's now a prime contract arrangement. I think, Ian, and the governance is such, I think that needs board approval. I think the plan is to go to March board, is that right?
Yes, I think that is correct.
I think the extension allows that.
Yes.
So clearly we are looking at that bid both this month and next month at Business Committee, and as Ian mentioned, the NEDs at Business have made themselves available to attend other bid sort of challenge sessions, but expect to see that coming through to board at March. Other than that, I was going to take, happy to take questions. I'm sure Azra will be as well.
Any questions, colleagues? If not, I mean, a real big thank you to Azra and your team. I mean, hugely challenging time, as Jo said, ever-changing complexity in all of this, and really well done. So I think we'll quit while we're ahead on that one. So thanks very much on that. And then Jo, I think we're into you on partnerships.
Yeah, partnerships. So just to say, and you know, I think it's moved on since we had our last meeting with the situation. Really big improvement in partnership working with LGT. That seems to be going really well. And you know, particularly given the current acute situation. You can see there's some notes there about Section 75 arrangements, particularly in Bexley. There is quite a hard end time for those negotiations, and that is quite tricky. So I think that will be coming through in the next few months. But particularly given the situation in Bexley Council at the moment, you can see in the operational report that is producing some issues. And Committee in Common, there were no approvals on Committee in Common. The minutes from the September Committee in Common have been provided as part of the appendix to the papers. We had a good session with the on the Committee in Common this week, beginning to think about the next phase of the strategy for the SLP. And I think that's going to be quite an active thing over the next 6 to 12 months. So at some point, probably on away day, I guess, I think we should bring, as that begins to formulate, we should bring that to the board to look at on the away day. There's certainly no dearth of opportunity. It's a question of where we go, I think. Again, other than that, I was going to take questions.
Any questions for Jo on partnerships? If not, thank you very much indeed, Jo, and we'll move on to infrastructure and Suzanne, please.
Thank you, Chair. I've just noticed that the heading for the report is Infrastructure Committee Minutes for the meeting in 20th of October, which might have confused some people because we have actually met since then. In fact, we've met twice. We've met in November and December. I just wanted to note that we'd introduced the additional November meeting in part because of the capital expenditure controls, which are now being exerted at ICS level. And we wanted to make sure that when ASRA, as our DOF, entered the kind of negotiations with the ICS, that she was fully cited on what we thought were the real priorities and stuff that we could potentially leave, investments we could potentially defer. So I'm sure that people have read the cover sheet, so I don't want to add much more about it. What I did want to do, though, is just draw to your attention that we need to seek your approval of capital expenditure for IT equipment. The reason for this is set out in the cover note, which is that we've had to bring forward some of that expenditure in order to spend a bit more of the anticipated capital expenditure that as I say, the anticipated capital expenditure for this year. I know that Alison and indeed ASRA, I think, are still on the call. So if anybody want any further explanation of that, I'm sure they'd be happy to answer questions, as indeed am I.
So just to clarify, so you're asking this board for authority on this expenditure, is that correct?
Yes, I mean, my understanding is, and I think ASRA probably pointed out that that goes above our limit for approvals at Infrastructure Committee. ASRA, I can see that your hand is up, so ASRA could probably explain this better than I can.
Okay, so what this was actually linked to was, overarchingly in London, there is an overarching capital control total. We were forecasting an underspend across London, and therefore there was a request for people to bring forward any of their 21-22 capital expenditure. And specifically it was that. So what they were looking for is the capital regime next year is going to be extremely tight. So it was, how would we be able to reduce the ask for 21-22, whereas at the same time upping the forecast outturn for this year. We had the discussion at Infrastructure Committee, and Alison was able to identify 1.6 million that was sitting within our 21-22 plan that she could bring forward into this year, spend and make sure it was booked and banked in the 2021 expenditure, and therefore that was that actual request. It came at quite short notice, which is why we had to try and deal with it via infrastructure, just to check that it actually did work and that we would be able to manage that and then reduce our 21-22 ask. But it is above the limit that we can sign off at that committee.
Stephen, please.
I'm looking towards Sally here on the sort of governance. My gut feeling is if we're going to put requests like that to the board, and I appreciate the time issues, the board members would want to see some sort of more detailed paper. Sally, any views?
Excuse me, what we could do is agree it subject to circulation of background paper and then sign off outside of the meeting.
Yeah, and that's what I was thinking as well. Yeah.
Okay. Yeah. And just to say, we have the paper we'd be able to take completely off the stocks and be able to process, so we should be able to get that done today. Yeah.
Good way to do it. Yeah.
Yeah, I must admit, it might be my fault for not reading that so much in detail. It didn't leap off the page at me when I was going through the front sheet. I suppose what I would have preferred would have been a separate case, perhaps, that we could clearly identify as an item on the agenda on its own right. But just to go over this again, so I don't add any obstructions to this. Just sum up again, Azra, please, in a few words, what you're asking for today.
Right, so linked to what Suzanne had said earlier on, the Infrastructure Committee sat down and looked at what the expenditure requirement on capital would be for 21-22. Within that expenditure requirement was a 1.6 million IT requirement that was needed around additional remote working. So basically making sure that the agile working practices and the strategic direction of travel around more agile working would be able to be managed. So it's principally around equipment, and Alison may want to come in with a bit more detail on that subject. All we're simply doing is taking that requirement that was a 21-22 requirement and purchasing those assets in 2021. What that will do is reduce our requirement for capital next year and increase our forecast. And if you look through the finance report, you'll see we're actually, even ourselves as a trust, we are not hitting what our capital plan was. We had a plan of circa 20 million, and we're only, even after we add in that 1.6 million, going to outturn at 18.6 million pounds worth of capital. So broadly, we had already agreed to infrastructure that we wanted to spend the 1.6 million, and I think Alison will be able to give some more details, so we'll hand over to her shortly, and then just simply bring that forward to this side of the 31st of March.
Yeah, hi, thank you. Alison, please.
Yeah, thank you. Yeah, apologies. The more detailed paper did go to infrastructure, but obviously isn't in the pack, so we can certainly get that circulated today. And as Ezra said, what we've looked at was what could we bring forward from that 21-22 capital plan into 2021, and predominantly it's infrastructure to support the agile working programme. So it's moving us to a predominantly laptop estate across the whole organisation outside of inpatient wards and associated equipment related to that, so monitors, phones. We're looking at a soft phone solution that will enable staff to have phones on their laptops, etc. So it's the infrastructure to support agile working for the next 4 to 5 years.
Yeah, sounds full of stuff. Stephen.
Yeah, just to confirm, I'm okay with it as such, but I just think from a board approval point of view, the way that Sally suggested, I think is the right way to go. We could provisionally approve it here if everyone was so minded, and hopefully within 24 hours, having seen some sort of just some background note, because as Ezra and Alison have explained, there's perfectly good reasons for doing this that we actually benefit. But I think if we're going to ask, nevertheless, NED approval, board approval of £1.6 million, yeah, it should have something a little bit more detailed to back it up.
Yeah, thanks, Stephen. Suzanne, please.
I just wanted to thank both Ezra and Alison for being able to explain clearly to the board what it is we're proposing doing this. Thank you. Yeah,
okay. I mean, this sounds like eminently sensible. We're going to spend it anyway next year. But echoing Stephen's point, we just need a paper that lays out what we're going to spend. We are asking board approval here, so let's have a board approval paper straight away, please. I can't speak for others, but I doubt very much that anyone would disagree. I just want to get the governance right on this one, if we could, please. If there's nothing else on infrastructure, we'll go on to workforce, please.
Thank you, Andy. Again, I'll take the report as read and just draw out a couple of highlights in the order in which they appear in the report. Actually, we had an issue raised to our attention from the Junior Doctors Forum about the ability of junior doctors, and particularly those who work for us on a locum basis, to access RIO and the impact that may have on patient safety. There's always more to these things than meets the eye. So we had a lengthy discussion in workforce where we made the point that we cannot be the only trust to have this issue. So we were keen to get under the skin of it. And I believe that it is being brought forward again to workforce next week for a fuller discussion, so that we can understand more what's there and what can be done about it. We had a very long discussion on health and safety. I will summarise that by saying that everyone around the table was very keen to have an annual health and safety report come to board. That report will be coming to Workforce first next week at our meeting, and there are a number of areas where committee members want to escalate the visibility of health and safety issues and how those issues are being addressed, and want to bring more structure to how we at board have oversight of health and safety, to reflect good practice, best practice from the Institute of Directors and the Health and Safety Executive, and to also ensure that the processes that we're following on health and safety are resulting in the outcomes that we are seeking to deliver, given the nature of what happens in that space. We were very mindful that the health and safety team is in the eye of the storm in terms of the role that they have from an incident response perspective. So we are trying to tread a line between gaining traction on these issues as quickly as possible, while understanding that they are also in a very intense role at the moment. We had a report on new ways of working, which we have touched on from an IT perspective. We heard about the work that's ongoing to enable us to work in a more mixed economy model, not only in terms of the ability to work remotely, but equally the ability to work flexibly. There's been really positive feedback from both staff and patients, and we acknowledge that this is a longer term change that will require change at the cultural level from an IT support perspective, and in terms of support that's needed for managers to adapt to a very different way of working over time. We've already had a very helpful report from Rachel, and we've approved the values and the behaviour work that's been ongoing for a period of time. We also had a discussion on the risks, our key risks that in fact we had reported in detail to the Audit and Risk Committee the day before the last Workforce Committee meeting. We've had a number of discussions, I won't repeat those, on the key workforce risks, which are obviously demand and burnout. On a more positive note, we had a very interesting update on the Trust Apprenticeship Scheme, where almost 2 years ago we had 23 apprentices, and in the next few months we are due to reach 107, which is a massive achievement. It's a massive achievement in terms of what it means for adopting innovative ways of working, and the apprenticeship levy. But we've also had, in fact, earlier this week, Rachel and I and Sally had a discussion with London South East colleges, which was a really refreshing insight into additional work that we can do in that space. Nothing more from me, but happy to take questions.
Thank you very much, Nina. We've got Sue, please.
Hi, sorry, it's Sue here. Just a couple of questions based back onto the issue of locum doctors and not being able to log into Rio. Given the recommendations from the CH inquiry, that would seem to be quite an important aspect of ensuring records. And I don't know how you manage that within Oxleas in terms of any agency or bank nurses. Do they have access to the Rio system if they're working? Because it crosses the professional boundaries, isn't it? It's not just doctors who would need to enter records. It would be nurses and whoever else is employed on a bank or an agency basis. And I suppose it's looking across and ensuring they have access to be able to enter contemporaneous records, because that's so important. And given what we've heard from the earlier report from the CH inquiry, it could have a major impact. Thank you very much, Chair. Thank you.
Thank you, Sue. Alison?
Thanks, Andy. Yeah, I just wanted to respond to the issue of the locum access to Rio. As you can imagine, if it was an easy problem to solve, it would be solved by now. We've been looking at the issue with colleagues in other organisations, and we've got some recommendations or some options that we're looking at that will go to be discussed in detail at the next Workforce Committee. The issue predominantly relates to locums and out of hours access. So for nurses who work for us for a longer period of time, we generally resolve the access issue very quickly, but it's particularly over those weekend periods where we have a locum join where there are some particular thorny issues to resolve. But there's a detailed paper and we can discuss that at the next Workforce Committee.
Thanks, Alison. I don't. It might have changed, but I remember a few years ago, and then quite bitter that you have agency nurses who are earning more money than them, and then going off duty earlier than them, while our staff update the system on their behalf, and they do the double whammy of insult. And I don't know if that's changed at all, has it?
Sorry, Andy, I didn't catch all of that. You broke up, but I don't think that would have changed into the end of the conversation.
Yeah, I don't know. Iffy, can you come in?
I still hear from clinicians, particularly. I think the last time I heard this was with district nurses, for example, that sometimes agency staff aren't able to operate real or don't have access, and therefore existing substantive staff have to make those entries. So it does still occur.
So remind me, Alison, where does this come back to?
So the locum issue is going to be discussed, I believe, at the next workforce committee.
Next week.
Yeah, and there's not missing the point around nursing staff as well on this one. I'd be interested to know where we got on that. Suzanne, please.
So just a question about workforce issues, because it was a feature of the operational report that we're having difficulty in some areas mobilising our waiting list reduction plans because we can't get staff. And I was just wondering whether we're experiencing difficulties in the same areas as our other partners, or whether there are some things specific to Oxleas which are making it difficult to recruit in some particular areas.
Come in on that, Andy? Shall I come in on that?
Yes.
So I think there's a problem. I think there's a problem right across the board, Suzanne. We are really struggling. We're trying to be as creative as we can. So when anything goes to agency panel, we kind of reflect on the different ways in which we can be creative. If it's a different band could work, different alternatives, different sort of skill set could work. We try and be as creative as we can. But there is a widespread problem at the moment, as you might imagine, in trying to access the right staff. But we're doing our very best.
Thanks, Rachel. Ian?
Thanks, Andy. I think Rachel's probably covered the points I was going to make, really, that there's a kind of wider context to these challenges. I mean, one of the things we are trying to do is to work more collaboratively with other providers locally. And that's a feature of a lot of the system work, not only in say, Bexley and Greenwich, for example, but across South East London, across all our service lines. So, yeah, it's ongoing.
Thank you, Ian. Are we all done on workforce? If so, thanks very much. And we'll move on to audit and risk. And Stephen, please.
Thanks, Andy. Yeah, just to pick up a couple of points from the notes there. First of all, thanks to Iffy for giving us a very good presentation on care planning and risk management on that area. Just to explain why we did this, under the terms of reference for the Audit and Risk Committee, Section 7, we do have some oversight of new processes. So we don't look at every new process that we do. And obviously it does go through subcommittees, but now and again, we'll look at a new process. So we do appreciate it would also have gone elsewhere. It would also have gone to other committees to look at, but quite good at us just to look at the efficacy of the process when it's first starting. Secondly, on the internal audit update, well, succession planning, I think all the NEDs will know that this has been an issue for us over many years. So I think we're getting to a good place now. What we're looking to do in the next couple of months is for Matthew, if he would be so willing, to just give us an oral update at a NED Away Day of how he sees the existing structure and perhaps the future structure for Oxleas. And also at a later date, we've agreed, as Rachel carries on more work, to get succession planning embedded throughout the organisation as a system, we will review that plan in a more detailed way, and we're very happy with where we got to that stage, because we'll be a lot better off than where we have been. Complaints, well, it's quite nice to see a good trail from a NED away day to action being taken, which is again taken a little while, but it was raised at a NED away day a couple of years ago about how we record and deal with complaints on a public platform on the website and also through social media. And Michael Whitney was very, very supportive of this as well, for us having a look at it, as was Sally. So KPMG have had a look. We've got a significant assurance with minor recommendations, which is graded as amber green. There's going to be a policy put together by the end of January in terms of how we're going to respond to areas on the site, those sort of public complaints. There's a lot of good things, I hasten to add, came out of it. KPMG were very complimentary that our policy is adhered to fairly consistently across the organisation, that complaints do have a dedicated investigator who has got relevant experience, in other words, taken from the relevant directorate that's involved. And we do have, and I've got the number here, 335 investigative officers. And last year we had 328 complaints. So we've got enough officers to carry out the investigation and deal with the complaint. So generally it was very favourable. Also, we did pretty well on responding to the issues that were raised in particular complaints. The recommendations will be introduced over the next month. Some we're already doing. One of those being getting to a faster response time. Our mean average had previously been 24 days to deal with a complaint response, but that made it very difficult to put 24 days to do the initial report, and then the response was required after 30 days. So that 24 has now been brought down to 15 with the support of the executive. So that's good. So that means it gives us a little bit of a better time frame to put the final response together. So all in all, KPMG very happy with us now on how we deal with complaints, and we've in fact made a significant step in broadening the fact that we now recognise complaints in social media. Workforce, thanks to Nina to come along and present the various risks from the workforce. Particularly interesting to hear about risks associated with COVID, staff under stress, the changing work environment, and all the mitigations that are taking place on that. I thought it was particularly interesting hearing the conversation about the high numbers of staff over 35, and Rachel C was involved in this as well, and the plans to cope with that in case we're faced by that wave of early retirements. And it was good to hear as well that what Nina and her committee were saying, and the risks, how they were being managed, that very much reflected with the audit and risk NEDs on their visual visits to staff and what they'd heard from staff in terms of the issues sort of at the front end. So happy to take any credit. Oh, I should ask Nina, is there anything else you wanted to add to that?
No, thank you, Stephen. That was really comprehensive.
Thank you. Happy to take any more questions.
Stephen, I'm back in the room, having been dropped out.
Sorry, I just got to the point. Any more questions? Sue, I see Sue has got her hand up.
Yeah, thanks very much. Thank you very much for a very interesting report, and I think it covered many issues. Pleased to hear about the succession planning, because that is a big area that doesn't always get addressed within any organisation, let alone the NHS. I suppose, looking at it, you are not going to be the only organisation facing the age issue, if you like. People are opting out earlier these days, and I think with the impact of COVID, as we come out of it, hopefully, that could be higher than you're expecting. And I'm not quite sure how you manage that as an organisation. It's almost running with it as it happens. But I'm pleased to see that you're actually attempting to manage it and looking forward rather than waiting until it hits you. So well done for that piece of work. Thank you. Thank you, Chair.
Thank you. I will. Nina's got a hand up. I will bring her in a second. The other good thing through the South London partnership that one can see gradually developing is that there are more career opportunities across the three organisations. So I'd like to think as well that is going. And there's a danger there. You know, we could lose staff to elsewhere, and equally we could poach staff from elsewhere. But I'd like to think it would lead to some greater retention because there's more opportunities available, and we're doing more services because we've got a greater scale. Nina, can I bring you in?
Thanks, Stephen. We had a really interesting discussion as workforce non-execs with Rachel before we came to Audit and Risk Committee around this, actually. And I think there were two strands to the discussion. One was, and Rachel and Debbie had done a lot of work on this to understand that we were more or less in the pack in terms of the number of staff and the percentage of clinicians that we had who were in that kind of 55 and above age bracket and who might be able to qualify for early retirement. And the question then arose around how much can we do as a trust and how much can we do as part of the SLP, for example, versus actually needing a more national system-wide response to this. Within other sectors, there are tried and tested and very effective models of using retention tools to address the problem before it becomes a problem. And I'm not sure that I'm seeing at that national level what's happening in that regard. Understand that we're in crisis management mode at the moment, so it might be something that comes further down the line, but I do think that's a really important aspect of the response. More locally, I think we were encouraged that anecdotally, the suggestion seems to be that staff are so committed to the NHS and to trying to help us through the pandemic response that the pressure point arises almost once we start to emerge out of this, rather than it being an issue that we expect to crystallise over the next few months.
Thank you, Nina. I also see Matthew has made a mention about complaints. It's on the chat, Matthew. You probably don't need to say any more, do you, or do you?
It's just the clinical teams and service directors who do the complaints are busy, very, very busy at the minute. So the kind of whole process of managing complaints, we haven't been given the sort of freedom to handle it in a different way. So there will be a dip in performance, a definite dip in performance for a month or two here until we get back on top of it. But we will.
Thank you. That's all from me, Andy.
Such indeed. If we can move on now to the board visits, just going in the order that they're in the paper. I only need to highlight any particular issues that people want to bring to the attention of the board. We have the report in front of us. Look here on the call that went on that visit.
So I went on the Meadowview visit, and I have to say, I think it was one that was done virtually because we suspended some of the site visits in Bexley for a while. So it was really useful to be able to go back in. And I think it was really appreciated by the members of staff, being able to have some of that communication coming back through and then understanding some of the features that they were experiencing going through that process. And you'll be able to see at the bottom, I think you've got 2 board visits attached for Bexley, that we did actually have a series of action plans as well that we were able to put into place, just recognising some of the issues that they had raised with us. I wasn't going to say anything other than that, other than the fact that it was really useful to reinvigorate those meetings again.
Yeah, thank you. The next one on the Children's Community Nursing Team, Ian and Alison are on that one. Who's going to speak on that?
Yeah, I'm happy to go first. I'm sure Alison will join in. Yeah, I think it was largely a positive visit. I mean, I think one of the difficulties for the children's, for the nursing team is just the kind of changes to restrictions, but they're kind of managing that extremely well, and also just how they work together as a team, you know, given the current circumstances. But I don't know what Alison thought, but I thought they indicated very successfully how they've embraced technology, and they feel well supported by the directorate team.
Yeah, I mean, I thought it was a really positive visit, and would echo what you said, Ian. They were very upbeat, considering the circumstances.
I think these really good, these visits. I'm just wondering about the actions and the deadlines. I don't want to add another layer, but remember how we capture these, because on that one for Lisa and the concrete area, deadline December 2020, and on access to clinic diary from iPad is January 21. This would have looked at it, done it. How do we capture these actions?
Hi Andy, we're due to bring back a report to the board actually of an update on action, so I can take that forward to the next March board and bring something back.
Yeah, I'm very conscious. I mean, there's so much else going on. What I don't like is going back in a year's time and find everything done it because we've been overwhelmed or whatever. But just capturing those actions if we can. The next one was rapid response, and Ezra again. I think you're the only one on the call that was on that one.
Yes, again, I mean, most of the features that we've done is we'd always talked about what the impact of the pandemic had been on the team. And this particular team had obviously had an increase in the amount of work that they had coming through. They'd identified a couple of areas, coming back to some of the points that we'd had around workforce earlier on in the meeting, where they had come to agency panel. And one of the issues they had said is they'd perhaps asked for a Band 7 post, couldn't find one, but could find a Band 6 member of staff who would be able to help out, but they had to go back through the agency panel again. So we resolved that, I think, within 1 week of a discussion at the agency panel, just to say that we would allow it up to that level. And then there were there's some long-standing issues around space for that rapid response team. And we really saw that actually on it's a very small office. And they had to do, it was quite difficult to socially distance on the call when the members of the team were effectively coming through. So the directorate management team will be taking on board, you'll see about 3 actions, which were just really about process, the last one being about mileage costs and clarification with the HR department on those elements. Again, I think they really appreciated the visit. And I think it's a real opportunity to just show frontline staff the interest that the board had in what their day-to-day lives were, and giving them an opportunity to really voice any issues that they had.
Well, thank you for a busy schedule for getting these things done. I suppose it's how do we get these going again. I'll take a bit of guidance from you, Matthew. But I really think these are quite useful, and if we can get them going across all of the trust as soon as we can, it'd be really helpful. Matthew.
Yeah, I mean, there's no doubt that the staff really like seeing senior management. They like seeing leadership from within the trust and having the conversations with them. It's that against balancing how much time it takes up for them. So I think the key thing is, fairly short, fairly supportive interventions that don't require them to pull together any sort of data packs or information at the minute. That's those sort of brief drop-ins. The problem at the minute is it kind of has to be virtual, so it takes a little bit of organising. The more we can avoid needing sort of chaperoning with service directors and others, the better as well, because it's about how much. I know Sally and her team have been helping out a lot around the visits and really making sure we support about them. But I think people just really welcome the thank you, they welcome the drop-in, they welcome the opportunity to share. And as Azra said, there's some stuff we can put right really quite quickly. There's some stuff we can fix. Other things like the rapid response office, which is tiny, and that whole building there is pretty rotten. It's on LGT's estate. It's like every time I go and see the DNs there, it's parking. and how do you access the car park? Same for liaison. You know, some of these are pretty intractable things, but I think they feel better from having told you about it. Do you recognise that it's rotten? So yeah, I think the more we can do to keep them going, but they need to be very low burden at the minute and not feel like a sort of internal assurance visit. That's absolutely not the tone to take. But soon we'll all be vaccinated, so we can get back to out with the boxes of donuts again. You know. So.
Yeah, thanks, Matthew. I was just wondering if we can get it really small teams. Yeah, if it's just 3-4 people, rather than asking for a big all singing, all dancing visit. I think it'd be really good to see that going again. Thanks for doing those. If we could just move on to the.
So I mean, some of the really interesting ones. For example, the older adults liaison team who work in QE, rapid response, and other, they're really, really impressive. And some of them, because they don't really cause as much trouble, they don't get much contact from us. Because they don't appear anywhere on risk registers, because they tend to manage their stuff really, really well. So there's something about us steering us towards people who probably don't get as much attention as some of the other services, and just making sure they get that fill-up, because they do feel the benefit. And that came through in the conversation with the shadow exec, actually, how much people welcome speaking to people from across the organisation at times, particularly just now when it feels like we're all in a bit of tunnel vision with COVID.
Yeah, thanks, Matt. Really good. Start thinking about how we can revive the visits, make them pretty small, not needing the director to hold our hand, no presentations, just talking to the staff about the issues that they've got. If we can start to do that, revive those again, be really helpful. If we can just go on next to the new councillors that we got on board and the ones who've been re-elected. Thank you very much for coming forward on that, and everyone else can see what paper. Are there any questions at all on the Council of Governors paper? If not, we'll go to any other business. Nothing's been notified to me. I can't see. Just one thing, Neil, of course, I neglected to say right at the beginning that, Neil, this is your first formal board, isn't it?
Yeah, thank you.
Board member, is that it?
Yes. No, but thank you. Yeah, no, it's been really, really interesting. Yeah, look forward to contributing.
No. No, apologies for not working at the beginning, but thanks very much indeed. Matthew, please.
Yeah, I just wanted to say, I think most of the board are aware of this, but Jazz Thind, our finance director, successfully applied for the post of Director of Finance at Imperial in North West London. She's the first female Director of Finance of one of the London teaching trusts in history as well, so it's a really significant appointment for her. And I received her formal resignation yesterday, so we're just going through the process in relation to her replacement. The members of the board are aware of that through the appointments committee process, but I just wanted to publicly acknowledge that we've now received Jazz's resignation, so we will write back to her and put on record her thanks for her years of many service at Oxleas, and also I think the fact that someone who has been such an integral part of the trust has gone on to such a significant job in the London finance world is really significant as well, so we'll wish her all the best.
Yeah, absolutely endorsed by all of us, and send our thanks on to her as well, please. Really, really pleased for her. It's a great achievement and a great appointment for her. In the absence of anything from anybody else, just want to say again, huge thank you to all of the exec and all of the staff for everything they're doing. The great news from Matthew about the vaccine spirits, doesn't it? If we can get as many of our staff done as quickly as possible, that will be fantastic. And then move on through the rest of the risk groups. Absolutely brilliant. Yeah, again, huge thanks to you all. Very good meeting. Very grateful. And we'll now sign off. Thank you very much indeed, and look forward to seeing you quite soon.
Thanks, Andy. Cheers.